Good morning. This is Tim Markle out of the Waisman Center. Just wanted to, number one, do a little bit of a test to make sure that the sites are receiving the signal and receiving the sound. And so we plan on starting in about 5 minutes. Our first three presenters are actually here and in the room. And so we're going to be able to get going right around 8:30, 8:31. So about 5 minutes, we will come back on and we'll start the program. Thank you so much for being here. So there you go, that's the official start. You can continue to talk now. Because I'm not going to do
One of the things that the medical conference has really taught me is that one of the phenomenon that occurs in lots of people with autism is how much their body will bend themselves over backward to save itself.
Great, thank you so much for that overwhelming response. I'm going to get my clipboard so I look really official. We ready to go? All right. Well, good morning, everybody here at the Waisman Center. Thank you so much for showing up so that our speakers will have somebody to talk to. I have done seminars before where it has been strictly online and it's no fun talking to yourself. And so I'm really excited that we have a nice crowd here this morning and a nice crowd across Wisconsin. Just so you know, we have over 30 sites that are joining us this morning, as well as at last count, people that were scheduled to be on their personal computer watch it was about 113. I am imagining with the continual news that comes in about be wary of large group gatherings, that our sites probably have less people than they anticipated. So I apologize in advance for that, in the sense that I'm sorry that it happened, but I totally understand people's need to take care of themselves. And so I do understand that. If you want to send me extra food that you have, that's fine. As long as it's non-perishable. Please do not send me fruit. It spoils by the time it gets here. But any non-perishable food that you have extra from your sites, please feel free to send to me. That'll be just fine. And coffee. You can send me coffee. I reheat it. What a week it's been. I do want to start off this morning by just reminding people about who the Community of Practice on Autism Spectrum Disorder and Developmental Disability is. And that basically is all of us. 10 years ago, there was a grant through the federal government that went through the Department of Health in combination with the Waisman Center to look at the systems of care in Wisconsin around autism. One of the efforts that they undertook was a community of practice, gathering the people in Wisconsin whose interest was improving the system of care around autism, bring them together, learning together, looking at problems together, solving those problems together, and continually trying to change the system to make it better. Better for parents, better for people on the spectrum, better for the providers caring for those students and young adults and adults on the spectrum. 7 years ago, the grant ended, and one of the things that everybody said they wanted to continue, everybody, so we took a vote, and a majority of people, maybe not everybody, said that they want to continue was the community of practice. And so because of dedicated people on the steering team, such as my co-chairs on the steering team, Ann Harris and Kelly Brodhagen, who serves as the parent co-chair, the steering team reconstituted itself and has continued to offer these events without any major funding for the last 7 years. This year, we have over 700 people registered to attend at sites or from home. That wouldn't happen without a lot of hardworking people. This year, we have had Raydeen Yang, who is a LEND trainee, who has been instrumental in providing this day. And she is here on site. We will clap for her later because nobody else will be able to see her, so it'd be kind of silly. But she is here, and I thank her. But also wouldn't happen without our different sites. So bear with me. Feel free, if you're at a site, you could give a cheer when your site is called. If you have 2 people, it'll be awkward, but do it anyway. So we have joining us this morning through the Aging Disability Resource Center of Door County up at Sturgeon Bay. We have ABA of Wisconsin's Potter Road Center in Wauwatosa. The Board for People with Developmental Disabilities, this is their first year joining us in downtown Wisconsin. We thank them, downtown Madison. CISA 3, some of my friends out in Fenimore. Love my Fenimore friends. Feel free to eat at Timothy's Cafe. There's a Timothy Benedict that is fantastic. I would love to say that it's named after me, but it's not. But I like it anyway. My friends in Portage at CISA 5, and then my friends up north at CISA 12 in Ashland are also joining us. Coming back this year is the I am so sorry, guys. Chequamegon School District. Everybody in Madison is like, yeah, sure, sounds good to me. Those in Park Falls are going, that was horrible. But up in Park Falls, thank you for joining us again. We appreciate that. Another returnee is the Cholita Institute down in La Crosse. I believe for the first year, we have Dunn County Human Services in Menominee, Wisconsin joining us. And then coming back this year is the Elkhorn Area School District in Elkhorn. Lakeland Care came on board this year and opened up 4 of their sites in Fond du Lac, Oshkosh, Green Bay, and Wausau. Marathon County Health Department in Wausau with the Northern Regional Center for Children and Youth with Special Healthcare Needs. We have Marquette University Interdisciplinary Autism Initiative joining us this year. Mid-State Independent Living Choices in Stevens Point is a site again this year. Nick Lake College in Rhinelander has joined us. I know Oshkosh North High School is also a returning site. We have Racine Unified School District in Racine, or Racine, depending on how I feel like pronouncing it at that time. Southern Wisconsin Center has opened up their doors in Union Grove. Stevens Point Area School District at the Professional Development Center is also a site. Our great friends who are able to put up with me not getting them the stuff that they need at UW Superior to offer you CEUs. So if you did register for CEUs out of UW Superior, I have promised to get them the paperwork they need to grant you those CEUs by the end of today. So they're awesome, and they're very patient, and they're very kind. But they also have a site besides offering CEUs. Wisconsin Early Autism Project also opened up a number of sites, including Eau Claire, De Pere? Really? Huh. That's as bad as, when I used to pronounce Shawano. That was always fun. Where are you going? I'm going to Shawano. And they're like, no, you're not. There's no such place, Tim. Okay, I guess I'll go to Shawano, which is not how it's spelled, but anyway. And also the Wisconsin Indian Head Technical College in New Richmond has also opened up a site. We have 2 sites that are closed sites, is they didn't have space enough to open it up to a lot of people, but they really wanted to offer it to their staff. So Life Academy in Green Bay is joining us today, as well as the Waisman Center Outreach over on Olin Avenue in Madison also has some of my colleagues joining them today. One of the things so thank you, all site coordinators and all people that have gotten in their cars and gotten out of their site. Last year, it was a snowstorm. This year, it's COVID-19 that causes us a little issues. So part of me says, I can't wait to see what 2021 is going to bring, because there's no way I could have anticipated what 2020 brought. Did want to let you know of a couple of statewide opportunities that are coming up. The 31st Annual Autism Society of Greater Wisconsin, their annual conference is coming up April 30th through May 2nd. So please check that out. Always a fantastic conference, a lot of families. Families also are gathering at the Circles of Life Conference, which will be May 7th and 8th. The ASGW Conference will be at Kalahari. The Circles of Life, May 7th and 8th, will be at Glacier Canyon Lodge in the Dells. And then for those down around the western and southwest part, is Cholita, in cooperation with University of Wisconsin La Crosse Extended Learning, is going to present Changing Lives, Developing Self-Regulation Skills for People with ASD. That'll be June 15th through 18th in La Crosse. So you can check that more out. I will do my best to remember to link the things that I just talked about, along with the evaluation that you will receive after the conference, after the event. And we'll also let you know how you can, if you need a certificate of attendance, we'll let you know how to get that certificate of attendance after the event. I would encourage sites during the first break, during the first discussion, that if you have local interest events that you want to let people know about, such as support groups, such as adult support groups, such as dinners, whatever may be happening, play groups, days at the library, please share those with your local groups during the discussion time. At the end of each section we will have a couple of discussion questions to be able to send out to the groups to be able to aid your discussions. All right, that's it for me, and I'm thankful for that. Thank you again for being here. I am so excited about our lineup today. And so we're going to start with Martha Walter. Martha is a licensed psychologist at the Waisman Center. She received her PhD in school psychology from University of Wisconsin, Madison. So she is a Badger through and through, and we're excited about that. I'm excited to run into Martha quite often in the building, and so I'm very grateful that she is here. She was just recently doing the same sort of presentation for Day with the Experts, Autism. And so we loved her so much that we said, please let our group know about this as well. And so please welcome Martha. Feel free to clap. Yeah.
All right. Well, thank you so much for having me. All right. So I am, as Tim mentioned, a psychologist here. I work in the Waisman Center clinics and a few different clinics here, as well as a research project. So during this presentation, I'll be talking about a few different things. I'll talk about anxiety and how we think about anxiety as a disorder, the overlap of anxiety and autism, behavioral approaches to managing anxiety, and then a brief note on medication and autism. So first, I'd like to talk a little bit about anxiety and what that can look like. One way to think about it, or one way to understand anxiety, is that when there is a danger in our environment, that could be a fire, it could be a huge animal approaching, someone breaking into our car or house, a type of alarm goes off in our bodies. And this is a good thing because it helps our body to be able to recognize the danger and respond to it. However, some of us have what we might consider more overactive or false alarms that go off, that either go off more frequently than other people's, or in times that there may not be a true danger. So for example, if your body's alarm goes off when someone's car drives by rather than someone breaking into your car, that might be a way to understand a false alarm. And this can be hard because it may be tricking our bodies into thinking there's more dangers present that there may not be. I think it's important to know that experiencing anxiety is a normal part of life. It's a part of the human experience, and as I mentioned, can be important and helpful and adaptive, because we really do need to be able to respond appropriately and quickly when there is a crisis. So anxiety becomes a disorder when a few things are true. One is if the anxiety is pretty significant and persistent over time. So if it's not typically reactions to frightening events, but it's happening on sort of a pervasive, common basis, if it's generalized and frequent across many different types of situations. Anxiety disorders also involve accompanying symptoms, which I'll talk about on the next slide. And finally, in order to diagnose anxiety, it must cause significant suffering or impact on someone's daily life. This is important because many people are anxious to some degree, some of the time, but for anxiety to be considered a disorder, it must interfere significantly with daily life or day-to-day functioning. So this slide summarizes some of the symptoms of anxiety that we may see. And the presence of these symptoms may in part differentiate anxiety from an anxiety disorder. They can include feelings of being tense or nervous or restless, having a sense of impending danger, physiological symptoms including increased heart rate, breathing rapidly, sweating, trembling, feeling weak or tired, and then other types of things such as trouble concentrating, trouble sleeping, gastrointestinal problems, or having difficulty controlling the feelings of worry. So the current manual that we use to understand and make anxiety disorder diagnoses is a mouthful. It's called the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or DSM-5. There are many different types of anxiety and anxiety disorders that people can experience. They're listed here. So, for example, generalized anxiety, separation anxiety, selective mutism. I won't go over all of these today, but I did want to mention it because there are many different ways that anxiety can present in different people, and it's really important to understand which type or types of anxiety someone has, because this can have a really big impact on how we think about supports and treatment for that individual. There are certain types of strategies and treatment approaches that are fairly universal, but there are also going to be differences depending on the type of anxiety or anxieties that a person has. Okay. So first, I thought it might be helpful to talk briefly about how common anxiety is in general. Depending on what source you read, and I looked at many, many different ones in preparing for today, you will see different estimates. A common estimate is that it is close to about 20% in the general population, and that's true for children, adolescents, and adults. Again, depending on the source that you look at, you will see different numbers, but that's a general ballpark. We typically see that overall it's a little more common in females than males. And one survey showed that approximately 31% of adults will experience an anxiety disorder at some point in their lives. So as you may imagine, these numbers mean that it is one of the most common psychological sort of differences that we have in our community. All right. So of course, we are really interested in thinking about anxiety and autism. And so there have been a number of different studies that have looked at the prevalence of anxiety symptoms and anxiety disorders in individuals who have autism. And there is a far greater range, as you will see. One study notes that it was a meta-analysis that looked at many different types of articles and reviews, and it indicated that estimates range from about 10% to 80%, which is a huge, huge, huge spread in terms of individuals who have both autism and anxiety. A more common estimate that people use is closer to around 40%. There have been a few studies that have been at this 39, 42% mark. And if you go back to our previous slide where we said about 20% of the general population has anxiety, you can see this is about double at least, if not much more, depending on the source that you are looking at. There are many different hypotheses for why this might be true, whether there are differences in how individuals are being assessed, or how we are kind of conceptualizing anxiety for that person. It also may be impacted by how the person communicates their anxiety and whether that's they're able to share that in a sort of verbal way or if they're showing it in other ways, which we'll talk about. And so there may be many explanations for why this is true. It also could be due to the sort of population or sample that they were looking at in those studies. There's also been some research looking at those specific anxiety disorders for individuals with autism, and you can see, again, ranges for the different types of anxiety disorders, with one of the most common being specific phobias, which are those very specific fears of a specific situation, so such as a fear of dogs, injury, needles, some of those specific types of what are called phobias. There's also been interest in looking at whether there's any other factors to consider for the prevalence of anxiety for individuals with autism. And what we see is that anxiety is present for all individuals who, across different levels of sort of what they conceptualize as cognitive functioning, but that the type of anxiety might differ depending on the population. Again, this is another area where there's huge variability depending on the study that you look at, but some studies have found that those with higher scores on cognitive tests have been associated with more anxiety with OCD or obsessive compulsive disorder and separation anxiety. And some studies have shown that individuals who receive lower scores on IQ tests that they may have more social anxiety, and some studies say that there's more anxiety. So it just really does depend on kind of what you're reading. And I think is an area for us to try to understand more about in the future. So in terms of what anxiety might look like for someone who has autism, I think one is that it may look just like anybody else, as we talked about those characteristics on those symptoms on a previous slide, such as those physical or physiological symptoms like rapid breathing, increased heart rate, sweating, but sometimes it may present differently. And so some of the things that we might want to think about or look out for when we're thinking about anxiety might be if there's kind of increased emotional lability or like emotional fluctuations. A really big thing we want to think about is if there are certain kinds of behavioral differences that we see, such as an increase in aggression or anger or self-injury. If we see emotional responses that don't quite match the situation or what their typical response has been to those kinds of situations. If we see withdrawal or refusal to participate in activities that they previously enjoyed or liked to participate in. If you see some depressive symptoms, that might be a clue to look out for anxiety as well. And if there are sleep difficulties, which, again, may be true for anyone who has anxiety. All right. So one thing that people often ask or want to think about is, so what's going on? Is it anxiety or is it autism? This is an important and difficult question to answer sometimes. And part of that reason might be that there are sort of symptoms or characteristics of both that might appear overlapping. And so one thing that's important to note is that anxiety is not a core symptom of autism. So a person does not necessarily have anxiety if they have autism. Although it is more common, like we saw, 10 to 80%, that is not 100% of individuals, and it's not sort of part of making a diagnosis of autism. One of the most common things that we might think about, or a situation where we might be more likely to make an anxiety disorder diagnosis, is when someone has a marked change from what their sort of what we call baseline functioning was. So if we think about what was daily life typically like for this person, and what did they enjoy doing, and who did they engage with, and how did they engage, and we see a significant change from what that used to look like, that might be a clue that there is something else going on that might be anxiety. We can also see new symptoms develop if we might be thinking about anxiety, or we might see things worsen or get harder for that person. And this may be particularly true when there's some kind of environmental stressor. So if you think about perhaps someone at school and there's some stress that's happening in the school environment, that might be something that might trigger more anxiety for that person. A couple other things we think about are whether sometimes if we're thinking about, are there specific types of fears that might be more indicative of anxiety? And then something else that we think about is, so if we're working with this person and we want to support them and try to think about strategies that might help them, if we take the approach of thinking about it as anxiety, or that it at least might be anxiety, and we provide some intervention and support for anxiety, and it gets better, that might be a really good indication that that's what was going on for that person. So it can be a tricky thing to think about, but these are some of the things that we might consider. So what to do? So either if you think that you may have anxiety yourself, or that your child has anxiety, or someone you care about has anxiety, there are some things that you can do. Excuse me. One thing is to keep track of the sort of symptoms or behaviors or characteristics or things that you're noticing. It can be really, really helpful to see if there are any patterns to those behaviors. And so we might want to think of keeping track of when is this happening, where this is happening. Are there specific triggers or things that seem to have caused that response or that reaction to happen? And then what does it really look like? So what one person looks like when they're anxious may be different than someone else, and so it can be helpful to keep some data on that for if and when you choose to talk to someone else about it. This is more specific to if it's your child, but talking with other people involved in their lives, such as their teachers, care providers, child care providers, therapists, talking to other people about what they're noticing and what they're seeing. And then talking with your child's doctor, or talking with your doctor if it's for yourself. One thing that one of our developmental pediatricians shares is that it can be really, really helpful to give the doctor a heads up before you come in for that appointment, or as you're making that appointment, so that if they have the flexibility to schedule a longer appointment, they could do that, so that there is more time to be able to fully go into that concern. And we'll talk about what that might look like in just now. Okay, so if you are seeking an evaluation for anxiety, either for yourself or for a child or loved one, or if you're referred for this type of evaluation by someone who is a care provider, this may take place in a few different places or with a few different people. One place might be with your primary care provider or a child's pediatrician. Another place might be with a psychiatrist, so a medical doctor who has specialized training in these types of things. Or it might take place with a mental health provider, so someone like myself who is a psychologist who may work with people who have anxiety. The specific components of what that evaluation may look like will vary, but in general likely would include an interview with the individual who's experiencing anxiety or who may be experiencing anxiety and their parents if it's their child. An informal sort of observation of that individual during that evaluation, information from other people who are involved in that person's life. That could be school if it's a young person. And then really important, and that may very likely happen, is some type of formal assessment through rating forms. And so there are many different forms out there, but forms that enable someone to be able to understand either what types of anxiety might be present for that person or how significantly sort of impacting that anxiety may be for that person. And there are different forms that individuals can complete for themselves, that parents can complete, or that educators can complete. Okay. So I will primarily talk a little bit about behavioral interventions or supports for anxiety. I'll briefly touch on medication in a moment. But in terms of behavioral approaches to treatment, the most common type that you will see is something called cognitive behavioral therapy, or CBT. CBT is a therapy that is a really substantial evidence base for a number of different individuals, both in children and adolescents as well as adults. So CBT is a structured treatment method that really targets reducing symptoms of anxiety by sort of enhancing that person's ability to be aware of their internal sort of emotional states. It teaches individuals to be able to recognize those, so to be able to recognize how anxiety manifests in my body. What does it look like for me? This is what it might look like for other people, but what does it look like for me? And then it helps us to also understand some of the more cognitive aspects of anxiety. So what are some of the thinking patterns or thoughts I have that might be contributing to my anxiety? And then it also helps us to think about, are there specific triggers for anxiety? And it does this by using a variety of different kinds of approaches. So there may be physical approaches like teaching someone relaxation to kind of be aware to cues in their body. It teaches cognitive strategies, like I just mentioned. So some of the conceptualization around anxiety is that there may be sort of internal thoughts like, I can't do this, I'm going to fail, I'm not going to be successful in that environment. And so if those are my internal thoughts, it's teaching someone to be able to be aware of them and then to try to change them. Engage in problem solving. And then the other aspect is some behavioral strategies. So one of the core components of effective anxiety treatment is something called exposure, which is a process of helping an individual face those feared situations in sort of a safe way and in a supportive way that they can use their strategies that they're learning how to manage it. And so those are kind of some of the core tools that we might use in CBT. And so generally in CBT, there's a period of sharing information about anxiety and how anxiety disorders develop, how it's treated, and then together the therapist and the individual or the individual's family are working together to get information about what that anxiety looks like for that person in the situations where they have anxiety, working with the individual to have strategies to manage that anxiety, and eventually face their fears through exposure. Often you will see CBT provided in a one-to-one setting, but sometimes there may be a group option available as well. Something else that's helpful to think about is whether there may be any sort of modification or optimization of other types of supports or interventions that an individual has, such as ABA, applied behavior analysis, or autism treatment, different kinds of therapies like speech and language, OT and PT therapies, as well as educational supports. It's really, really helpful for all people involved in someone's team to be sort of aware of the strategies that might be helpful in supporting that person. So if you have someone in your life who you care about and want to support, who may be experiencing anxiety, such as a child, but it could be someone else, There are a few things that we can do to sort of help. One is to communicate our empathy to them, to model sort of what that non-anxious behavior might look like, to try to prevent avoidance. So we, don't necessarily, if we have a fear of a certain situation, we don't necessarily want to completely avoid that situation, but we want to sort of equip that person with the strategies to be able to manage it. Helping, again, someone to use those coping strategies, and then sort of encouraging or supporting when they do use them. Typically, strategies that are not quite so helpful are being excessively reassuring, and on the other hand, too directive, permitting or encouraging avoidance, or being impatient. There are a few things we can also think about when we're working with someone who has anxiety, either at home, in school, or in the workplace, depending on your role with that person. So things that can be helpful are having organized and predictable routines at the different settings that they're at, helping that person prepare for transitions or knowing when there's going to be a change, providing supportive, structured, planned opportunities to be able to handle that feared situation when that's appropriate for the sort of part of their treatment they're in, giving them accurate information so that we can sort of dispel myths or misconceptions around the situation that might be coming up. Visual supports can be really helpful. It's a little bit small, but in that corner is an example of a feelings thermometer, so that's a way that we can help someone communicate their level of anxiety, and this can be super individualized to the person, and so that person may choose their own graphics or emojis or whatever it is, and then use their own language to describe what that anxiety means to them, and what does it mean for me to be at a 10 might be a little bit different than for what you might mean at a 10. So you can help them think about that and then also use their own language. Coaching and positive self-talk, like I did this before, I can do it again. I took this test last week and I did really well on it. I studied and I practiced. I studied and practiced for this one too. I can do this. Things like that. And then just normalizing anxiety, and that none of us are perfect, and that's not an expectation we have for anybody. Okay. I want to briefly touch base on medication and autism. These slides are from one of our developmental behavioral pediatricians here at the Weisman Center, Dr. Danielle Schulze. And so I talked with her and wanted to share just a little bit about medication with you from her perspective. And so she will talk about how medications do not treat the core symptoms of autism, but are used to address co-occurring things such as anxiety. And that with medication, we're thinking about targeting symptoms and functional impact, so trying to make sort of day-to-day life better for that person. That it's important to think about weighing benefits versus risks. You might be wanting to think about, are there alternatives to using medication? Are there side effects or adverse reactions that we need to be aware of? That response can vary from person to person. And her perspective is that it should always be combined with some kind of behavioral, psychological, or educational interventions. A few other notes about medications in children and medications in autism are that there are a few medications FDA approved for children under 6 years of age, that there are limited what some people may consider gold standard trials, which are randomized trials that have placebo or sort of a control group, and that are double blind, so that neither the investigators nor the people participating in the study know which of the sort of intervention groups they're in. And so there are limited trials for children, and even fewer studies exist for children with autism. There is one study I just wanted to share with you, and this with a caveat that this is not specific to autism, but this was a large trial that was done with almost 500 children and adolescents with anxiety. And what they did in this study is they compared a few different types of treatment approaches. And so one approach that they had 4 different kind of intervention groups. One group had that cognitive behavioral therapy. The specific program that they used is called Coping Cat, which is an evidence-based CBT program. So there was a group that had only cognitive behavioral therapy, There's the group that had only medication. In this study, it was sertraline. There was a group that had both the cognitive behavioral therapy and sertraline, what they called the combined group. And then there was a group that had a placebo pill, so a pill that did not contain the medication. And what they found through this study is that the individuals who were in the combined group, that had both the cognitive behavioral therapy and medication, had significantly better outcomes than the individuals who were receiving one single therapy. So they had 80% of the individuals in that group were found to be, quote, much or very much improved at post-treatment, as compared to people who had cognitive behavioral therapy only. They had about a 60% response rate using that definition. Medication only was about 55%, and then those who had no treatment or the placebo pill were 24% response rate. So that was just helpful to show, that, and this is important to think about what works for each person, and it's in consultation with your providers, but give some information around sort of the different types of response you might see depending on the types of intervention. Okay. All right. So I wanted to share a few resources. So on the left-hand side are resources for parents around anxiety, and then on the right-hand side are some resources for children and teens, and those are broken up by age level. I'll leave that up for a second. All right. So I think I finished 3 minutes early. If there's a time for a question or two. Sure.
One of the things in your the diagnosis criteria was irrational fear. So how is this different if there was a rational fear, like they actually did have a reason to be afraid? I mean, how would you change the treatment model?
Yeah, oh, sure. So I just want to repeat it for the audience and also to make sure I understand it. So one of the slides had mentioned an irrational fear, and so thinking about does or how would treatment differ if it's more of like considered a rational fear? Yeah. Is that right? Okay. So I think that's a really good question, and part of what would happen before we even do treatment is to do a really, really thorough interview and sort of evaluation with the person and their family, so that you can get a good sense of what that anxiety looks like for them. I think whether it's sort of rational or irrational, if there's a significant impact in that person's life, we still want to provide treatment. And so we may need to think about just what that might look like for that person. And so with exposure, for example, we're thinking about how to set up these different scenarios so that person can face that feared situation. And depending on what it is, if it's a fear of dogs versus a fear of shots versus some sort of more traumatic type of thing, it really can, how we kind of go about that can differ, because we can't simulate everything. And so sometimes we have to be careful and thoughtful around how we develop that program for that person. There's different kinds of treatment where it might be more what we call imaginal type of exposure, so where we're doing some exposure exercises more where we're kind of thinking about that situation versus a real, sort of a live in-person exposure to that situation. Because for things like, say, surgery, for example, we can't have a real sort of in vivo experience to that, but we might be able to be creative around how we can sort of practice some of those same skills, and whether it's through some more imaginal things or stimulating some types of things for them. I think it just is, I think for all types of anxiety, truly, it's so individualized in terms of how we truly approach it, even if the general overall approach is similar. So I don't know if that answers your questions, but we just really think individually about that person and carefully about how to set that up so it's a successful experience for them.
And
Yeah, that's a really good question and good thought. I think off the top of my head, I'm not sure that it's necessarily avoiding a strategy altogether, but being careful and thinking about what does that look like for that person? How are we going to implement it if we need to in a supportive and structured way? And so I think, and this is just thinking off the top of my head, but off the top of my head, I'm not thinking that there's something that would necessarily avoid altogether, but I think that's where having all the people come together to think about the sort of individual needs of that person and how anxiety looks like for them and when it might be triggered, that might really help us to think about how to carefully deliver other types of intervention for them. Sorry.
I was just going to
got
bounce
time?
off of what
Oh.
she said and say,
I just want to make sure you repeat and then this will be the last one.
Oh, yeah.
I was just going to say, trying to avoid extinguishing a pattern, a coping strategy that the child might currently have for anxiety, because without trying to replace it.
Sure,
I
yeah.
think that would probably be
Sure.
one that I would avoid.
Yeah.
Because right now, that's all that they have to cope
Yeah.
with
Yep.
anxiety, and so I would just want to replace that.
Yeah.
Like restraining them,
Yeah. So,
something.
right, sure. Yeah, so I think to repeat the comment that, thinking about how something might be a coping strategy for a person to manage their anxiety, and we would want to think carefully about whether to sort of extinguish or try to remove that coping strategy, and if it needs to try to be removed because it's a danger to someone or someone else, being really careful to think about how to find an alternative coping strategy for them before taking their only strategy away. Yeah. Okay.
Thank you.
Thank you.
All right, I'm going to play with the screen up here for a minute. Get us out of there. Thank you so much, Martha. I appreciate that a lot. As I learned stuff, even though I've been doing this for a few years, I still continue to learn different things. We want to continue on. I will have some questions afterwards for the group discussion sites, but we're going to continue on because we're really excited about our next presenter. We're going to bring up Kimberly Chan. She was born and raised in Madison, has a bachelor's in mathematics teaching from Edgewood College and associates in accounting from Madison College, which means she's much smarter than I am. Me and math, distant relatives, not friends at all. So if you're friends with math, wow, that's amazing to me. She currently works at Charter Communication as an accounts payable specialist. She's also a certified academic language practitioner and tutors dyslexic children at Children's Dyslexia Center of Madison. Why would they call it dyslexia? That is such a hard word to say and to read, but anyway. She's also a member of the Madison Ice Diamonds adult synchronized skating team. Again, something that I cannot do at all. Math and skating, we are not friends. She was diagnosed as an adult with dyslexia, anxiety, and autism spectrum disorder. We're excited to have her here to talk about her lived experience and help other people understand about how to help others. So glad that you could come out and join us today, Kimberly.
My name's Kimberly. My story begins when I was 5 years old, and I had teachers at school noticing that my hands would shake, and I couldn't write my numbers straight. And so they referred my parents to take me to a neurologist, who basically told my parents that my nervous system was growing slower than the rest of my body. So then I went through a couple years of OT and some interventions at school. And progressively, as school got harder, my anxiety got worse. Some of my biggest fears during school were tests. I had really bad test anxiety. And now that I know I have autism, I know that part of my issue is I have very hypersensitive hearing. So when I would sit in a quiet room and hear people write with pencils, it sounds like scratching on a chalkboard, if you can imagine that for like an hour. So that on top of having anxiety was not fun. And then it got really bad in college, so I was taking a French test and totally broke down, crying. That teacher recognized that I needed help, so she brought me to see the Disabilities Resource Coordinator at my college. And thankfully I went to a private college, so I didn't need an official diagnosis at the time. And I got to talk to a counselor, and he recognized that I had anxiety and was able to fill out the paperwork. And because I had no diagnosis and no help throughout school, I didn't realize all the accommodations that were out there for me. So I got to test in a quiet room. I got a student note taker, and all those things helped reduce my anxiety. So after graduating college, and still to this day, my anxiety and autism affect interviewing. It's a really big problem for me because I am socially awkward, and I tend to miss cues, and so I've probably done over 50 interviews and probably have only gotten like 4 jobs out of them. So then where my diagnosis comes in is when I was about 29. After deciding teaching wasn't for me, I was doing home health care. And at the same time, I had just been diagnosed with asthma as well. And they had put me on an inhaler. And so then I was taking care of a client. I had never seen someone die before. My anxiety got so bad, and I didn't know how to cope with it, and I was crying and crying and crying. And then went to my doctor, who prescribed medication to help with my anxiety, and then suggested counseling. So I ended up going to a teaching clinic, because I didn't have health insurance that would cover it. And it was there that she started noticing symptoms of autism, or the signs of autism. And so that's where I was diagnosed with autism, and pieces of the puzzle kind of started fitting together. And knowing that it wasn't my fault that I struggled to make friends in grade school, and it wasn't my fault that they moved away. Knowing that there was a reason that I missed social cues. And then decided to go back for my associates in accounting, and I was very scared. At this time, I had my official diagnosis, so I met with the Disabilities Resource Coordinator, got my accommodations, and I think one thing I've learned about accommodations is they don't give us an advantage. They just level the playing field so that we can succeed like any other person. Because without them, we would not be able to succeed and do our best. Within that time, I started advocating for myself. Started feeling better about educating other people, because before that, I was terrified. One thing that was hard for me is I didn't realize that there wasn't really many support groups out there for adults or resources. Also through counseling, and I'll mirror the other speaker on this one, is that medication is not the answer. You do have to do a lot of hard work. And I've been in therapy for about 8 years now, and still working on my coping mechanisms. And yes, medicine does help, but you have to work for those things. And I think another struggle for me where anxiety and autism come into play is in the workplace. I struggle a lot because I miss social cues. I don't always pay attention to when people finish talking, and so I sometimes can come across as rude. I struggle a lot in meetings because I'm afraid that people are going to say something and I'm going to be in trouble. And I think something that's really helped me along the way is being able to practice those experiences and being able to look back on experiences to have so that I know, okay, I've been through this, I can do it. One thing I would not recommend is a teaching clinic for someone on the autism spectrum, because going into it, I did not realize I was going to have to switch therapists every year. So to already have anxiety with transitions and to have to switch and retell your story to another person and retell your story and retell your story is very difficult. I think one thing is, like, now there's a lot more information on autism and anxiety. When I was in school, it was like, we're not going to help you. We're not going to do anything. And also, I'm dyslexic too, so I have that struggle too, and I wasn't told about that until 3rd grade when they told me I was behind in reading, and I did have to repeat 3rd grade, which did nothing. So, and like some things that I would recommend, like some strategies for me are learning coping mechanisms, learning calming exercises, just at work asking permission to step out of a meeting when you get to a point where you're too anxious, and to not be worried about that. And for a long time, I felt alone after my diagnosis because I didn't know about support groups, or I was too afraid to go to support groups. And then my therapist found the Awesome Adult Support Group, and I attend it now when I can. I'm back in school finishing my bachelor's in accounting. But just to know that there are other people out there who have the same struggles that you do, who face the same fears that you do, is really uplifting and kind of help you get through those challenging times. And I think family is important, and your support around you is important. Like, I don't think I would have made it through my schooling had it not been for my instructors realizing I needed help, my parents knowing that they needed to get a tutor, and just my hard work. So, and as I said, in order to make schools, jobs, all those things fair for everybody, we have to be willing to give those accommodations. And that's been my new fight at work, is for the first time ever, I've asked for accommodations at work to help me better cope with my anxiety and my autism. And it is a very long process, but it is out there. And also your HR person is your friend when it comes to that. And yeah, I guess.
Thank you so much. Do you mind if I ask you a couple of questions?
Yep, that's fine.
Okay, so yeah, go ahead and clap for Kimberly if you'd like. That's perfectly allowable. So a couple things you had mentioned, coping strategies and some relaxation type stuff. Do you have any specifically that you could share with us that seem to work for you besides the leaving the meeting, which I think is a good idea to leave meetings if you get too anxious. I think that's good for everybody. But what
So
other...
just like learning to do breathing exercises, because a lot of the fight with anxiety for me is when I get really anxious, I start to hyperventilate and I don't remember to breathe. So to do breathing exercises, to One of the new things I'm doing is EMDR, which is eye movement desensitization response, I think. And so what it is it helps you, so with anxiety, it's like not just the first, like an onion. You have to go back to that initial layer because it always starts somewhere. And with EMDR, it takes you back to your earliest memory. Like for me, I'm dealing with bullying right now because some things at work have triggered that. And with EMDR, it's helping me go back and put myself in those situations of my earliest memories and dealing with those memories instead of just letting them sit. And with that, the therapist will ask you questions like, how does it make you feel? Like, how does that memory make you feel? Where do you feel it? Is it, after thinking about it, do you feel better about it, you know? And the goal is to get to a point where you're like, okay, I've lived through that and I can move on. I think other coping mechanisms are just having things, fidgets to hold in your hands. I like silly putty and just other things to help you. Finding things like, for me, like coloring. Things to take your mind off things. Yep.
Does public speaking like you're doing right now make things better or worse for you?
So the question is, does public speaking make things better or worse for you? In other words, are you trying to insinuate that I was really mean to ask Kimberly to speak today? Is that what you're saying, Nancy?
So if you would have asked me, like, when I was in high school, I would have said yes. I've overcome a lot to do public speaking. I have realized that, actually going to support group, that if I don't speak up, who else is gonna do it? Because like half the people in my support group would not speak up. And especially with there not being a lot of data on adults or resources on adults. I'm learning to be more vocal about it so that our voices are heard.
I just want to say, just a comment, is that your presentation, it brings all of this alive and kind of upfront and personal in a way that nothing else does. And I just want to thank you for your vulnerability and helping me to, because as you've been talking, I've been thinking about my own son and the things that, who is now 35 or 36, and having some, I feel recognition. And I just want to thank you for your talk.
So the comment from the room was a thank you for the vulnerability, for the talk, that there is something about hearing a story that makes it more real, that brings it out more, and being able to connect to your own life and your own family. And I would definitely agree with that.
And I think just to give other people that there is hope, to have courage, and just to be vocal and ask for those accommodations and to not be afraid. Because when I was in college the first time, I was afraid to ask for accommodations. And I think that there is hope that you can succeed no matter what, if it's autism or anxiety. You may have to go about it a different way, but you can succeed. So.
I think one thing also I think needs to be pointed out too, and this can be
A source of anxiety.
that can sometimes be within people with different disabilities, is the tragic mindset that some people with disabilities develop, that if they meet someone who is disabled that can't do something they can do, that it is their fault. And I just want to comment that, every story
So the comment is that we have to be careful that even in the disability world that we're not setting up sort of judgmental areas, looking down or thinking sideways of somebody because they can't do something that I can do, and that we need to watch out for each other and not look down on others.
Yeah, and I was gonna say, for me, my new kind of motivation is I have struggled greatly in the workplace, and it's partly my lack of missing social cues, or, missing social cues, but also just having colleagues that don't understand that people need to learn differently and people do things differently and don't take the time. And then it gets to a point where I'm at now where I've had things happen at work where it's come to, I had to meet with HR and a colleague just so we can help each other better understand. So,
Please, there's a question in the back as well.
Feel free to say I don't want to answer this question, but in preparation for today, as an adult, knowing that when you were an adolescent you might not have done this, did you do any self-care or rituals or anything? Like, do you have something in your pocket that calms you? In preparation for today's talk and any self-care thoughts afterward, how might you be approaching doing today's talk?
So the question was, and Kimberly is free to answer this or not answer this, was there anything that she did in preparation for this talk to help prepare any techniques, coping skills that you're using to make it through the talk, or self-care that you're going to have after the talk to sort of come down a little bit afterwards? I know me, I'm going to go find chocolate. That's one of the things that I'm going to do when this is done, and probably some really good coffee somewhere. But has there been things that help you prepare for instances like this?
I think one thing is just doing like deep breathing before I talk has been very, very helpful, because when you're nervous, as I said, I tend to hyperventilate if I'm really nervous. So one thing I do to prepare for talks is just breathe, deep breathing. And I think something my therapist, the current one I have now, tells me to do after I do something that is a struggle for me or that I find difficult is to do something nice for myself to celebrate my achievement. And so probably today I'll probably buy lunch before I have to go back to work, because I have to go back to work this afternoon, but just doing something for me. And I did want to add something. So I did not know this till I started therapy, but as I said, I have asthma, and I did not know that, so I take a steroid inhaler, and one of the side effects is increased anxiety. So on top of having anxiety, I've had to figure out, okay, what is anxiety from my medication and what is anxiety from just being anxious. So just to be aware that other medications can also increase your anxiety. So.
Yeah, that whole sense of being aware of, medications or the stressors in life that are coming at us, to be able to identify what those might be, because that could change how we cope with them. So that's really cool. Any other questions? Yes, please.
I would love to hear more about your support group if you're willing to share.
Sure.
Individuals all with the diagnosis, parents, is there structure to the meeting?
So the question, do you mind if I repeat it? Or, okay,
yeah, you can.
Thank you. The question is, tell us more about this support group, about, what do adults who have autism when they get together? What does that look like? What are you guys doing?
So I go to the Awesome Adults. It's through the Autism Society of South Central Wisconsin. You don't have to have an official diagnosis. You can be autism adjacent, which means you think you have most of the symptoms or most of the characteristics there are a lot of people who are diagnosed with autism, and it is a pretty structured meeting. We have general meeting stuff, and then we usually decide on a topic, and then we go around the room, and each of us have a chance to talk about it. And then after that, we do kind of a follow-up, and then we conclude with how we felt the conversation went. So, and we meet once a month. So.
Once a month, okay. Cool, and that's about, how many people are showing up? That's right in Madison.
Yeah, do you wanna?
Hi, I'm actually the facilitator for that group.
So we do have the facilitator of the group here, Scott, so he's going to provide us a little bit more detail.
In terms of the number of people, we have somewhere between typically 13 and 20 people most months.
For some reason, Scott says there's 300 people. That is the most amazing group in the world. No, oh, I'm sorry, I misheard?
Somewhere between 13 and 20.
13 and 20, okay, so somewhere between 13 and 20.
At any given meeting, yeah.
Okay, thank you.
No.
Any final questions? Well, I would like to personally thank you for taking a morning off work and joining us here.
No problem.
You were fantastic. I mean, this was just wonderful. Thank you so much, Kimberly. All right, we're going to go ahead and break for some discussion at viewing sites. And so I do have a couple of questions that I would like the sites to consider. I tried last year to do discussions in this site as well. We'll see if you're any better of a group than we had here last year. You look more intelligent than last year's group, so I think we're going to do just fine. If you were here last year, whatever. So some questions for the group. The teams is I would love the teams to the sites to talk about what does it take for a team to support someone who has anxiety and autism? Who's involved in that support team? How does the communication happen? Specifically, how do you help identify someone who may be struggling with anxiety and autism? How do you make sure that intervention is across schools, work, home? Make it consistent for that person. And then how do you track when they're stabilized? How do you know when that anxiety is under control? So who would be involved in that sort of support? One of the things that I think about with Kimberly's story that would also be a good point of discussion is the importance, and the follow-up with the support group, is the importance of relationships. To live in isolation can be very hard. And so what is it? Is there just a monthly support in an area that could be set up to support adults and teenagers who are dealing with anxiety and autism, or just autism, that would be available? What could be done for adults in your area? The other question for groups is, okay, if we're dealing with autism and maybe people that are diagnosed with autism spectrum disorder and are dealing with anxiety, what resources are available in your local area to be able for that person to reach out and also receive some mental health support for those challenges? Because we know that each community is different. So ideally, we would love you to discuss this for about 15 minutes in your groups. We'll come back online shortly at around 10:15. Possibly if you could be a couple minutes early. We do have some extended announcements that I have been made aware that I have forgotten. And so we will make those forgotten announcements at the beginning of the next one. So we will rejoin everybody together at a couple minutes before 10:15. So thank you so much. Enjoy your discussions, and we will reconnect in about half an hour. Thank you.
battle starts higher of females to teenagers, which you pick up from your work buddies, you know, to say that you're struggling. The challenge is the parents before, so this is the despite their logical arguments, that this gender differential norms
All right, thank you so very much. Kudos to the group that has gathered here at Waysman. I will report out that they did a fine job on their discussions this year, so I do not need to shame them this year, even though I do presentations on shame, and shame doesn't work. But we had a really good discussion. I hope your sites did too. To give you food for thought, a lot of our discussion, not a lot, but some of our discussions centered around at what point do we need to look at how the world changes, that it's not us that are the issue, but it's how the world views us and how the world views differences, and that maybe it's not us. And what is that interaction? So it was a really good conversation. The announcements that I forgot, number one, all slides that are available to me will become available to you as soon as I get them loaded on the Connections website. You will receive that link because you have registered. If for some reason you found the link and you didn't register and you're watching us, which is fine, you're more than welcome, but if you do not send an email, we will not know that you're there. And so you will not get the slides or the information for the recordings. So if you are watching on a personal computer and you did not register, please send an email to tmarkle, M-A-R-K-L-E, @wisc.edu. Everybody else, I already have your email address, and so I will send out the link for the slides. I will send out the link for these will be posted on the Connections YouTube site, and so we will send out the link where they will live for you to review or share with people as soon as we have them ready to share. The other announcements that I forgot is excellent conference that I am fortunate enough to present and attend every year is the Children Come First Conference that will be held November 9th and 10th at the Kalahari. For families, very much focused on families and professionals who are helping those families who have children who have emotional and behavioral challenges. It's a fantastic conference, would endorse that one as well. And James handed me our annual reminder that part of our intersection, anybody do Venn diagrams when you were growing up? Yes. Yeah, anybody love Venn diagrams? Yeah, you're weird people. Very, very strange people. But if you think of a Venn diagram of anime and people with autism spectrum disorder, we have a feeling there's going to be a really large combined circle there. There's going to be a lot. So there is the No Brand Con, which you can find out about, nobrandcon.org. Will be April 17th through 19th at Chula Vista. For some reason, the 24-hour video games will be available, which does not sound healthy to me. But 24-hour tabletop games would be available, which also doesn't sound...
24-hour event is a big part of anime culture in Wisconsin.
Wow. Okay, so going all day, 24 hours at a time is part of the culture. The older I get, the farther away from that culture I get. It's just because... Oh, it's not a forced 24 hours? Oh.
It's a big part. Having something open, though, is a big part of Wisconsin culture.
Yes.
To the point where one of the big conventions, last year they couldn't offer it for 24 hours, and it really hurt their attendance because people expect it.
So James is now schooling me on the anime conferences, and that the 24 hours is a definite part of that culture and part of the conferences, and that it's really important. So, but not forced, but not mandatory. So that's April 17th, 19th, nobrandcon.org. And I
Plus, Madison's anime convention went out of business last year, so this is
Oh.
one of the local conferences.
So this is the most local in the Dells. The Madison one is not going to be happening.
After 12 years, it went out of business last year, which was really sad for the community.
Okay. Thank you very, very much. We're going to continue on with, oh, this is embarrassing. Thank you.
Not Persicki.
Okay, so I have called Connie Persicki a friend for many, many years, which is really embarrassing because that's not how she pronounces her last name. Persick. Oh my gosh. Okay, so Connie Persick, who I have known for many, many years, is a highly experienced speech-language pathologist, educational consultant. She has her own firm, CP Consulting, but I know her as someone who I run into her all the time at education conferences, previous community of practice, really talking about what does this look like in the classroom and how can you help the kiddos in the classroom. So I'm hoping that's what she's going to talk about today. So Connie, thank you so much for being here.
Hi. I'm going to try not to trip over these cords right in front of me. Jeepers. My name is Connie Persick, like Tim said. I am a speech pathologist by trade, and I had the pleasure of working in a school for kids with autism as my very first job. Coming out of graduate school, fell in love with that population of students. We probably had the kiddos that had more significant externalizing behaviors. That's why they were at our school. The school districts couldn't support their needs. And I did that for about 5 years. And just like I said, fell in love with behavior, fell in love with autism, and have been in the school settings in a different way, shape, or form for the past 20 years. So today I'm going to talk about anxiety and autism spectrum disorder, how we can help out at school, what it might look like. Let's see, I'm left-handed, so this is going to be interesting. I've just got to switch. That's okay. But I live in a right-handed world, so I can't use my left hand for that. All right.
Thank you for accommodating us.
Yes, you're welcome. All right. So in my presentation, I am using identity first language, which is recommended per the guidance of the APA style manual. I will tell you, though, I'm in a habit of using people first language when I talk. So while my writing may say autistic students, I'm not going to promise I can do that the whole presentation. I may be saying students with autism, just out of pure habit. But there's a real push in the autism community that, you know, autism is nothing to be ashamed of, and that's a part of their identity. So there's a big push to use identity first language. So today we are going to talk about, oh, my joke didn't get in there. I have to start with a joke, and I took a picture in the bathroom. For those of you that are on site, there is a visual right above the lock in the bathroom that shows how the lock door looks. So it has a picture of unlocked and a picture of locked, and I thought, oh my gosh, this is a perfect example of an anxiety decreasing strategy, because I don't know how many of you guys, but I'm definitely someone who will go to the bathroom that I'm not familiar with, and Then I start to panic, like, did I lock the door? Is it locked? Is it not locked? And I have to lock it a couple times to make sure. Well, here at the Weissman Center, they have visual supports for that. It is amazing. I added it on my phone, but it didn't make it to it didn't transfer over the cloud. But what a great strategy. It's a perfect example of ways we can help decrease people's anxiety. Anyway, today, we're going to talk about some prevalence rates in autistic students. I'm probably going to skip over most of that because Martha did an awesome job of, there's a little bit of overlap in what Martha and I are going to be talking about, so I'll just kind of skip or go through those a little bit more quickly. Recognizing the signs of anxiety in students with autism in the school setting, what we can look for, why we need to be looking for clues, and then some instructional practices that we can use to help all people who exhibit anxiety, but especially help people with autism. And then I'm going to talk to you about just a few for time's sake. And Tim took some of my time, and I always need as much time as I can get. But I'm going to I picked out a few strategies that are both top-down strategies and bottom-up strategies and top-down strategies that can help people with anxiety kind of get through their day, and some coping strategies that Kimberly was talking about. So, prevalence rates. I thought this was a really powerful quote that Temple Grandin often says. The principal emotion experienced by autistic people is fear. And for those of you who haven't watched The Sensory Funnel by Asperger experts, I would encourage you to do so. It's on YouTube. But he talks about that also, that the prime emotion people with autism feel is fear, and he even says like terror, because they're trying to fit into a world that doesn't meet their needs. And so, especially when it comes to sensory needs. So, the question was to repeat the reference. The reference is The Sensory Funnel. It's a YouTube video, and I can't remember the man's name, but he runs a channel called the Asperger's Experts. So, and he talks about that too. So, when it comes to prevalence rates, Martha talked a lot about the actual percentages being a wide range depending on the studies that you look at. Most commonly, they reference about 40 to 50% of students with autism have at least one diagnosable anxiety disorder. But this I thought was really interesting. Parents often report that anxiety impacts their children with autism more than autism itself. And there's a strong correlation between autism symptoms and anxiety symptoms. So the higher the anxiety is, the higher the symptoms of autism. Those symptoms of autism can become more prevalent as anxiety exists. So why is the prevalence? We talked a lot, like Tim said, over our break here, that there's a big part of the prevalence rate for anxiety could be that we are not as a culture, not accepting of differences as we maybe ought to be. So just somebody with a lot of differences trying to fit into this world is going to produce anxiety. Is it about anxiety in themselves, or is it about living in this world that's not as accepting? And I think there's a big push at the state level with the Department of Public Instruction pushing out their neurodiversity trainings and moving away from disability-labeled trainings, but how can we support the needs of all kids, no matter what they look like and all of their differences, and accept those? So I think we're getting there, but we're not there yet. We're at least having the conversation. But also, there's a strong evidence base for intense responsivity to sensory stimuli, especially as young kids. If you're more responsive to sensory stimuli in your environment, then you're going to have a stronger sense of fear and anxiety. Even if you have autism or in the general public, if you have sensory needs, especially if you're sensitive to sound and touch, you're going to be more likely to have an anxiety disorder or be diagnosed with an anxiety disorder in the future, especially if those go untreated. So we want to definitely be noticing those sensory differences and providing supports around them. Okay. So, task frustration. A lot of our students with autism have difficulty understanding abstract language, have difficulty with reading comprehension. We're not always giving them the modifications that they might need right away. So to be given that work from the get-go without the modifications, that's going to spike their anxiety right away upon presentation. So being aware of that and trying to really differentiate their needs is going to help us. Rigidity is a characteristic of autism. And so having difficulty with transitions, having difficulty if something doesn't go the way you think it should, having a hard time with change, all of those things are going to produce more anxiety and fear in somebody who already struggles with that. So that's why the prevalence rate could be higher in this population. Communication differences. For the students who struggle with communication or as a young child needed more visuals to help them communicate, their early experience in life has been that people don't understand them. So I see this often, even once we get an alternative communication system in place, those kids have an underlying, or those students have an underlying sense of anxiety around whether or not they're being understood. So it's really important that we acknowledge their communication attempts, let them know that we've heard them, let them know that we understand them so that we can ease some of that. Also in our students that are more verbal and are able to communicate, there's a strong correlation of word finding difficulties or retrieval difficulties in people with autism. And so that's kind of the chicken or the egg, what comes first? Does the anxiety cause them to have a hard time retrieving words, or their difficulty retrieving words, does that cause anxiety? I don't think we really have an answer for that, but think about how you would feel if you were in the classroom setting, you get called on unexpectedly, you know the answer, but you can't find the words to use to answer that. That's pretty anxiety producing. Almost every single student that I've evaluated for word finding difficulties have a lot of anxiety in the school setting also. There's a strong correlation there. So communication difficulties definitely can be a part of the reason that there's a prevalence for anxiety in students with autism. Social differences. I'll never forget my first IEP with a mom who had very flat affect. I couldn't read her facial expressions. I didn't know what she was thinking. I became a blubbering idiot. Like, I'm thinking in my head, like, is she mad at me? Is she okay with what I'm saying? Does she like my proposal? What's going on? And so when you think about people with autism, they have a really hard time understanding what other people are thinking and feeling and their perspective on the world. And if you go through the world like that, that can be very fatiguing and very anxiety producing if you can't read someone's facial expression to know what they're saying. Also for social differences, and I think Kimberly alluded to this, like, oftentimes, especially if kids get older and their awareness increases, they have a hard time, in a social situation, they know it's not going well, but they can't put their finger on exactly why, and that can produce a lot of anxiety also. So those are some of the reasons the prevalence rates are high. I'm not going to talk about this in my 45 minutes. I think I have 15 minutes now. No, I have a half hour. My half an hour today, but it's really why we have to make sure we focus on optimizing the therapies around these skills also. And Martha alluded to that too. Beyond just addressing anxiety, we want to make sure our therapies and our supports and the services we're providing students are beefing up these skills also, because just by doing so, we're going to help decrease some of the anxiety that exists. And during our break, we were also talking, this is such a fine balancing act, because so many students with autism bring so many joy to people and they have such great strengths. We don't want to change who they are, but we want to help them in those social situations so that their peers are accepting. I mean, it's twofold. We need to be teaching the environment and the other students how to accept their differences and welcome them and embrace them and celebrate them, but we also want to be teaching some of these skills so that they're not constantly struggling in those situations. Okay. So, why we need clues. Recognizing anxiety in our students can be really hard in the school setting for many reasons. And so one of them is a lot of kids with autism, or a lot of students with autism, don't have the vocabulary of the emotional vocabulary yet. They might have happy, sad, mad, but when it comes to worried, anxious, nervous, those are higher level emotional vocabulary words. And so a lot of our students might not have that yet to be able to tell us that and explain that to us in a way that we typically would be hearing from other kids. Even if they have those words and that vocabulary, as they get more anxious and they climb that anxiety curve, they are going to lose that skill to be able to tell us that. So when our mind starts to feel anxious, our body gets ready to fight. It gets ready to protect ourselves. It gets ready to either fight, flee, or freeze. When that happens, all the blood flow goes to the downstairs brain, as Dan Siegel coined it, the term. So we have a downstairs brain. Downstairs brain is responsible for our fight-flight. It's responsible for survival. It's responsible for emotions. And as a student gets anxious, all the blood flow to their brain is going to be going to that area. So the upstairs brain, which is responsible for communicating, responding to language, answering questions, problem solving, rationalizing, that's going offline. As soon as the trigger happens that causes the anxiety, that upstairs brain is starting to work less efficiently. So even if you have a student who has that vocabulary in an isolated setting in their speech and language classroom, at home, they might not have it in the school when anxiety starts to rise. So that could be why we need to watch some of our students' skills and their body and what they're doing to try to determine if there's anxiety existing. I also think it's really important for us to remember that as students learn social and emotional skills, there's a shade of knowing, which we totally understand when it comes to academics, when it comes to reading, when it comes to math. And actually, Fontes and Pinnell created the shades of knowing when it came to literacy knowledge, starting from not knowing the skill yet, to flexibly knowing it and it being habituated or integrated into your life. We get that when it comes to academics. We get that maybe a child can read a word in isolation, but not read it in a book yet. But we have a really hard time understanding that when it comes to social emotional skills. So keep that in mind, that even if your child has, or your student has calming strategies in the one-on-one setting, it doesn't mean that they can go and use that in the cafeteria when their anxiety is starting to be high or when they're dysregulated. I hear it all the time, but they had it yesterday. They could do it in my speech and language room. They could do it in the classroom. That just means they're learning it. It might not be fully mastered yet. So that's another reason we need to be watching our students and looking for clues of anxiety. So Martha went through a lot of these already. I'm not going to repeat them, but there's behavioral, your body responds to anxiety through behavior and through physical symptoms. So some of the behaviors I see a lot: perfectionism, avoidance, being afraid of making a mistake. A couple that I forgot to put on here: looking for a predictable response. If you see a student looking for a predictable response, you can probably beg to differ that there's some anxiety existing in their life. And if I do something and I know everybody's going to respond in this specific way, then that's going to ease my anxiety momentarily. I just observed a little girl, a middle school, she's not little, a middle school girl that needed pictures to communicate. She had a few words when it came to being able to echo them and speak in maybe one-word phrases. And as the end of the day came by, I could tell her anxiety was getting higher. She was repetitively asking for home. She didn't really know when that was going to happen. And that was raising her anxiety. And so in her last class of the day, she started rocking more, and she started lifting her shirt up so that the teacher would say, "Put your shirt down." And so it was this nice, predictable response that would happen. She would lift her shirt, the teacher would say, "Put your shirt down," and she would feel better momentarily. So if you're seeing things like that, that could also be a sign that, whoa, this child might need some, structures put in place to help ease their anxiety. Also asking for reassurance. Another elementary school student I just observed, he was continually saying, "Am I going to get in trouble? Am I going to get in trouble? Am I going to get grounded? Am I going to get in trouble?" And his teacher thought he was wanting to experience what trouble felt like. And I said, "No, I think he might be feeling some anxiety about whether or not he's doing the right thing, and he's looking for some reassurance at that point. He doesn't want to get in trouble. He wants to do the right thing. He doesn't want to experience that, but he's not sure exactly what the right thing is." So that can be another sign that we see in kids. We're going to talk more about this avoidance and school refusal and classroom refusal, because I'm seeing more and more and more of that in students, especially as they get into middle and high school. Okay, physical symptoms. Our body responds also physically to anxiety through a variety of different, the increased urination, students having more accidents at school, bathrooming accidents. All of that is in response to our fight-flight system kicking in, sweating, muscle tension, dizziness, racing heart. I'm not going to read through all of them, but those are some things, especially for our students who maybe rely more heavily on visuals to communicate and to understand language. If we can watch for more of these physical symptoms, maybe we can start having those discussions on whether anxiety is playing a role in the students' programming. I do have to make a statement of, you do not want to be jumping to the conclusion that this is all anxiety ridden without talking to the parents, without having the school nurse, if we have permission, calling the doctor. Because time and time again, I've seen, especially in our students who struggle to communicate conventionally, that there's an underlying medical reason for some of these physical symptoms, and that's being missed because they're not able to tell us how they feel. And so if you're seeing some of these physical symptoms, I would urge you to talk to parents, to have the school nurse contact, if you have a release, have the school nurse contact their doctor, because there's been too many times that I've seen an underlying medical condition. And in this, especially if you're female, in this society, we're jumping to anxiety right away before medical pieces, and we don't want to make that assumption either. So you have to be having some good communication. I just was called in, I think 2 years ago, to a high school student, transitioned to the high school from middle school, was itching like crazy, had a huge flare-up in his eczema, they thought, and wasn't going to class, having a lot of outward behaviors. Everybody assumed, they brought in another consultant, she was talking about it being anxiety-ridden. They were doing all these supports around anxiety. I came in and I was like, why did we jump to anxiety? He's itching until he bleeds. It ends up he had a rare form of cancer that caused him to itch. So I have seen it too many times to not put that caution out there. So just because these are signs and symptoms of anxiety, make sure you're having those conversations with the team, especially if they're a child who struggles to communicate in the conventional form. So some signs of long-term stress could be fatigue, headaches, migraines, nausea, stomach pains, neck, back pains. If you're seeing some of these in your students, then you might want to bring up, hey, is anxiety playing a role here? Do we have to talk about this as a team? Some other techniques you can use besides just watching for students, oftentimes I will have students fill out a Google form, like a distress level form, throughout their day. I have parent copies, I have student copies and teacher copies, so you can rank the student's distress level in each class. Parents can rank it on the way to school, on the drive to school. I would suggest making a rubric to determine what that child looks like as their anxiety climbs, and we'll talk about that a little bit more so that so it's a little bit more objective versus being super subjective. But sometimes when you have a kiddo not coming to school and you're suspecting it's anxiety, you don't have that privilege. So just to make a 5-point scale can work in and of itself without the rubric until you get to know the student more, what they look like as they get anxious. For kiddos who maybe need more visuals to communicate and to understand language, the 5-point scale is a really nice tool that they can learn pretty easily. It's very visual, that they could either point to 1 through 5 to tell you where they fall on that anxiety scale or distress level, or the people that are with them, the adults in the environment, could rate them if they're unable. And after a couple weeks of data, you guys could take a look at that and see whether or not you need to be providing some supports around anxiety. Okay, so we're gonna jump into some instructional practices. Studies of universal prevention strategies in school have revealed that if we put in some certain instructional strategies, that can have a reduction in anxiety for all people and have a really positive, beneficial effect on students who exhibit anxiety. So not only is it gonna help your students who have a diagnosis of anxiety or autism, but it's gonna help all the kids in your class. The number one, I guess I'm gonna have to say one of the top 2 intervention strategies that I would say is really focus on your relationships with your students. just by seeing your safe person, just by having somebody in your environment that you consider safe, that you have a strong relationship, that actually activates the vagus nerve, which will activate your calming system and make you feel calmer. So relationships have to be a priority for us in the school setting, for all of our students, but especially for the kids that are have more vulnerable nervous systems, kids who've experienced trauma, kids on the autism spectrum, students who have anxiety. We need to be making sure we focus on building a relationship with them. Also, everybody talks about teaching students to self-regulate. The beginning process of self-regulation is to learn to co-regulate with another person. Developmentally, that comes first. Co-regulating with, using another person to help you regulate. Seeing somebody who's calm will actually calm you down. So it's important when you have that relationship that as your student starts to escalate, you're really conscientious of remaining calm and regulated yourself so that student can use you to co-regulate. Really, sometimes I wonder if self-regulation even exists because we all use another person to co-regulate. We all do. If we get upset on our way home from work, we call our friend, we call our mom, we call our husband or our significant other. We're using other people to help us co-regulate all the time. And so by giving students that experience, we will be setting up the foundation for self-regulation, if that even exists, because I have a hard time. Well, I mean, I think it does a little bit, but we all rely on other people to self-regulate. And so to do that also, to build relationships, you can really work on empathizing with your students. I don't care if they need more visuals to understand language or if they have severe deficits in language comprehension. There's been a gazillion times I've seen somebody crying or extremely upset that people would assume don't understand language very well, and I've said, wow, Shelley, you look really scared right now, or wow, Shelley, you look really sad right now, and you can almost see their whole body calm down, relieve some of that tension. It doesn't matter who you are. That kind of empathy is going to absolutely help calm you down. So naming their emotion, which will, over time, help them learn what emotional vocabulary sounds like and what it is, what the words mean. Validating their feelings, empathizing with them, sitting with it for a while, telling them you're sorry, and how can I help you, is gonna be a really good way to build relationships. Also, making sure they have predictable time to have connections with other people. If you make it more predictable, it's gonna be less stressful for somebody on the autism spectrum disorder. So maybe at the beginning of class, you say, hey, Johnny, I'm gonna check in with you in 5 minutes and see how you're liking what we're doing in class today. Then you go over, you check in on them, you say, I'm gonna check on you again in 10 minutes. And you make that a really predictable routine for that student. Also, for students who rely more heavily on visuals to communicate, I've done topic rings where you take a picture of things that they love, things that they have at home, their pets, their family. You make a little script on the bottom so that they can go up to people and share those visuals if they can remember them and if they can learn those scripts and say what's on the script, that's great. If they can't, the communication listener can read it and they can have a little positive exchange and positive connection by having those visual supports. The 2x10 rule is another strategy that you could use. For 2 minutes every day, for 10 consecutive days, you're gonna just connect with that student around something that they love, around their passions, around their high interests, so that it's not gonna be about school, it's not gonna be about demands, it's not gonna be about what's coming up, it's just gonna be about something that they love. And for a student with autism, I would probably do that at the same time every day, so it becomes predictable. And by doing that, you can really strengthen your relationship. All right, there is a saying in neuroscience that says neurons that fire together wire together. And so we do not want a student going into the fight-flight response routinely over and over and over again, because that neurological pathway gets stronger every time it's activated. And every time it's activated, it becomes stronger in that part of the brain. They've even shown that students who experience trauma at a young age, which a lot of people are saying students with autism have brains similar to somebody with post-traumatic stress syndrome, just because living in this world can be very stressful for them. So that downstairs brain gets bigger over time the more it's activated. That neurological pathway gets stronger. So prevention is going to be super important. It's the same system That's activated when we're in chronic pain. That's why the doctors tell us, like, stay on top of your pain. You want to stay on top of your pain because you don't want that pathway to fight, flight, fight to get stronger. So think about it in the same sense as that. So sit down with your teams if your student can't participate. Rank the level of anxiety based on certain situations that they're in. And if there's little things that you can prevent, if the child's able to have that conversation with you, have them fill out a anxiety hierarchy, use an anxiety thermometer to tell you what situations are the most anxiety producing for them, what are the least. I can guarantee you there'll be some you'll be able to avoid. And like, while I don't promote avoidance for anxiety, there are some things that we can let go of that will help our student, like, prevent those triggers. An example, my own daughter has a very strong fight, flight, fight system. Totally typical little girl, but she has a medical condition that makes her fight, flight, fight system stronger. So when she goes into school late, which we're late often, but when she goes into school late and the secretaries say, Addison, I'm gonna walk you down to the office, walk you down to class, instantaneously that triggers a fight, flight, fight system. So we've just put a part of her health plan that I can walk her down, and nobody will say that to her. Because even if they say that to her, and she says no, and she knows she's able to say no, that still promotes that fight, flight, fight response. So we want to eliminate that on these little tiny things whenever we can. And so by having that discussion, you can start talking about, how do I prevent some of these triggers that are preventable, that we can just let go of. All right, you also, in the school setting, it's really important that we don't let avoidance take over when it comes to anxiety. People can respond in different ways to anxiety. They can avoid it, which is just avoiding that, thinking about the anxiety, avoiding the situation that makes them anxious. That's why you have some kids. I have a kiddo in 8th grade right now who is absolutely refusing. He's anxious about anything, but he's sitting in a room by himself the whole day, avoiding going out into the classrooms. He definitely has some underlying anxiety about going to class, but he won't even admit it because he wants to completely avoid that feeling. Or if somebody makes you go into the situation that's anxiety producing, or you decide to do it, you might white knuckle it, which is when you avoid the feelings and your body is like super tense, you start clenching your jaws. From that experience, you don't learn that while it was scary, it was still safe because you're still avoiding the feelings. What we want to do is teach kids to kind of live on the edge. You want to walk up to the edge, but you don't want to fall over. You don't want to get flooded with that overwhelming feeling of anxiety. It might happen. We can't always prevent that. And if flooding does happen, then we want to comfort the student and be supportive and help co-regulate them. But we want them to walk up to the edge, face their feelings, and then go back and relax and do something relaxing, do something that they love, and get distracted back into their setting. We cannot push. I mean, a great analogy is somebody who's afraid to swim. We can't throw them in the deep end and say, hey, good luck, go at it. And we can't let them continually avoid to go in water because that will just tell their brain at a subconscious level, this is really a scary thing. Nobody's even making me go in because it's so scary. So what we need to do is meet students where they are, provide the scaffolds and supports so that they can be successful, and slowly start increasing that time that they are in the situation that produces anxiety. So let's say you have a student who's avoiding music. A lot of reasons why that could be. Maybe it's a really noisy environment and noise hurts them. Maybe it's all the people in usually music rooms are really big, and so that space could be overwhelming. You want to brainstorm some of those reasons and give them supports to be able to be successful in that environment. But to start, perhaps you just videotape from their perspective, walking down to the music room, the classroom teacher waving. You let them do that for about 15 minutes, or 50, I'm looking at my time. You picked up your clock and I was like, oh no. You want to do that for a couple weeks. And then start having them walk down to the classroom and then go back to do something that they enjoy. Start having them walk to the classroom and wave to the teacher. You want to, and this is all going to be a completely individual decision, but you want to make sure, A, it's successful when they experience it, if at all possible. So you want to really be talking ahead of time about what scaffolds and supports to provide to make it successful, and you do not want to push them into it so that they get flooded with that anxiety. That's not gonna help us. And avoiding it isn't gonna help them either. The longer somebody avoids a situation, the scarier it becomes, and the more that anxiety is reinforced. Predictability, I'm gonna have to start talking really fast. Predictability is one of the best things we can do for anybody with anxiety. Make the world more predictable for them. That could be with daily schedules. That could be with mini lists if they have a task that they have to do. Try and think about these 4 questions that you can answer for them. What do I have to do? How long do I have to do it? What am I gonna do when am I finished, and what am I gonna do next? If you can answer those 4 questions in every situation, you're gonna make the world much more predictable for them. Waiting is one time that I think is really hard for people, like, how long is this wait gonna last? I mean, we can set a timer if we know, but if we don't know, it can be really hard to provide structure around that. So I have an example. So I kind of made my own wait, well, this is from the Picture Exchange Communication System, a wait card, but I added time markers to it, so then the staff can have bingo chips in their pocket, and if you don't know like how long it's gonna take to get through the lunch line, you can randomly just be putting your bingo chips on the wait card, and then when you know that your student's gonna get up to the front of the line, you put the last one on and say, we're all done waiting. So you've made wait much more concrete. It's one of the times I see a lot of kids really struggle with anxiety is when they don't know how long they have to wait. Also, if you don't have a daily schedule, which I would say have a daily schedule, but some people don't have a daily schedule for students with autism. At minimum, I think you have to at least, if they're a student who doesn't know how to tell time, has a struggle with time, you have to at least provide a visual to let them know how long they're gonna be in school. Because the passing of time can be really anxiety producing if you don't know when something's gonna end. So we've broken down the time of the day into 30-minute increments and just simply moved an arrow down by 30-minute increments. That could be one way to provide predictability around an end of the day. Because again, if you can't visually see when the end is coming, that's gonna be really anxiety producing. Okay, some bottom up approaches to support anxiety. This is really using the body to ease your mind. And so for your students who maybe have more difficulty cognitively understanding some of the supports that we want to provide, we can do some bottom-up strategies. Also, there's a ton of research in positive psychology now that says the more time you spend being calm, the less time you're going to be anxious. And so we can probably decrease anxiety just by giving them more and more time in calm situations, in times that they're happy, promoting happiness, and learning strategies around how to be happy is another way you can decrease anxiety instead of working on some of those cognitive behavioral therapies around anxiety. So here is a Shake It Up game. It's a mindfulness game by Susan Kaiser Greenland. You can do it online, or you can have the actual class play the game. She has a tool called Mindfulness Games, and in it, it's a box of cards. You pull out the card, and Shake It Up is one card, and you can teach your class how to play the Shake It Up game. Shaking your body can release some anxiety in a very safe way, especially like changing up the patterns of how fast you shake, going from being still to shaking, slow shaking, fast shaking. That will help release anxiety in your body. I'm not gonna play the video for time's sake, but it's on YouTube. Shake It Up Mindfulness Games by Susan Kaiser Greenland. I would say if you have a student who can play the game with the class, just do this game for your whole class. People love it. We did it in a mindfulness training I just did 2 weeks ago in Madison. We did it as adults and we loved it. And so shaking your body can really release some anxiety. Cognitive breaks. So these are more than just a sensory break, more than a movement break. Just leaving the classroom doesn't get you out of your head. You have to stop some of the worries in your brain and some of that negative self-talk that happens in anxiety, you have to be really engaged in something in a way that gets you out of your head. So Sudoku puzzles, crossword puzzles, reading out loud is a great strategy. Have them make like books for kids that are struggling with reading so they can read books out loud and put it on tape for other kids. You can't really think when you're reading. You can't be having all these negative self-talks going through your head. For kids who maybe struggle more with language and understanding language, I have found some of these sensory tasks that I've made super calming and organizing for them. So you have to go through that bucket and find all the heart stones. Heart stones are real things, like stones shaped into hearts. And you have to, dig them out with a spoon and put them in a box. Students who struggle with understanding language, that's set up in a very visual way so they know exactly what they need to do and they don't have to rely on your language. Creating a mandala, so imitating what that visual card says with all the pieces nice and organized, can be super calming for somebody and help get them out of their head. You can also, for some of those kids who struggle with language, give them time in their high interest. That's not a waste of time. Give them breaks to be doing the things that they love, because that's going to increase those happy hormones in their brain. It's going to give them more time being calm and happy, and that's less time being in fight, flight, and anxious. This used to be called Me Moves, but now they've renamed it to Calm Connect. This is actually an online program that you can get. There's about 3 to 5 minute motor sequences that you imitate. It doesn't matter if you imitate it correctly, it just matters that you try. And that activates the calming system of your autonomic nervous system. It's actually based on Stephen Porges's polyvagal theory. It's really scientifically backed. And so by doing these, I've got a lot of teams that say the only time this kid is calm is when they're doing Me Moves or Calm Connect now. They just renamed it. And I'm like, do more of it, because the goal is to make that calming pathway in your brain stronger than the fight flight. You want to make sure that that neurological pathway is really solid. So giving them time doing something like this is going to be really beneficial for the whole class, but really beneficial for your students struggling with anxiety. Okay, some top-down approaches. I have a minute. Can I go 5 minutes over? All right. For middle school, I love these anxiety and stress cards and growing happy cards. Like I told you, I have that little boy who is struggling, well, 8th grade boy, he's not little, struggling with anxiety. He's completely removed himself, sitting in a room by himself. I'm afraid he's gonna start to become really sad, because you can't isolate yourself for long without becoming sad. So we talked about just doing a tip of the day. This isn't about him. It's about when he does, we can put it on his board in his classroom now, but when he gets back to class, all the middle school students are going to have a tip of the day to like talk about and explore around one of these decks of cards. That's going to help the well-being of all your students, even though you're specifically doing it for one in particular. So these are some really great resources by Christopher Willard, I think, and Judith. Let me look at my notes. But both of them are on Amazon, and they're really practical ideas. One that stuck with me is telling yourself when you're anxious, how much will this matter 1 week from today? I'm a little bit more of a worrier than the average person, and so that's really helped me tell myself and give myself like some of that self-talk. Will this really matter to me in 1 week? So I'll leave these up here for the people here, and we can pass those around. So that can be really helpful. And then developing some positive self-talk scripts. For students with autism, you really want to make these visual. You want to be practicing them when they're calm, not when they're anxious, because really, when you think about it, anxiety can affect learning and memory so much, because as soon as they're anxious, that upstairs brain that helps you learn and helps you remember and helps you rationalize and problem solve, that goes offline. And so you don't want to be teaching these things during times when they're anxious. You want to be teaching them when they're calm. You want to be practicing so it can become flexibly known. And so you really want to teach them that their thoughts lead to their emotions, and that leads to their action. And so here's just an example of the same situation, 2 different ways you could think about it, and how that will lead to different emotions and different actions. The other visual there, you can add physical sensations to your little script if you want also. So if you have a thought that makes you more anxious, your heart is going to start racing. Your hands might start sweating. You can add that column in if you want also. Use what we know about students with autism and their learning style. Role play this, throw it on a video, let them watch it. Anytime you can put something on a video versus role playing, you're going to get more bang for your buck, because the evidence is really strong that by watching it, they're going to learn faster. All right, challenging those errors in thinking. Martha talked about this a little, but people with autism often have errors in thinking that cause them to feel anxious, like black and white thinking. a student might get a test in front of them and say, I can't do this, instead of, maybe I can do a little bit of this, but some of it might be hard. They just go straight to all or nothing type thinking. And so we want to start challenging those. They might be using words like everything, never, always, forever, instead of sometimes or today. And so what we can do is give the kids replacement thoughts for some of those all or nothing thinking. So let's say they said, I can't do this today. You can teach them, well, some of this test might be hard for me and some of it may not be, but I can do a little bit. Or you might have them rank their perception before the test of how hard they might think it's going to be. After the test, if you can get them to do it, rank how hard it actually was, and over time use that data to challenge their thinking. Like, yeah, you thought this test was going to be, you thought this math was going to be hard. For 2 weeks I tracked it and you thought it was harder than it actually was. And try to set up systems that will challenge those thoughts for them. Also, listen to their language and rephrase it. So if you hear somebody say, nobody ever wants to play with me, you could change that and say, oh, Johnny didn't want to play with you today, but Annie did, and kind of reframe their thinking to be more optimistic. Or let's see, another one, I'm not going to understand this, to you're struggling to understand this today. Not that they're always going to struggle, but today they might be struggling to understand this. You still want to acknowledge how they're feeling, but rephrase it into a more optimistic viewpoint. You also want to provide replacement thoughts. I've sat down with kids and over time you will start to learn their negative self-talk because they often say it out loud. But if they don't, you can say, hey, what are some of the thoughts that you have going in your head, around in your head? And many students that I work with are super honest. Like, nobody likes me, nobody cares about me. I'm no good at anything. And then set up a visual, make it really concrete. Something as simple as a T-chart. Here are your unhelpful thoughts. Here's how we can replace them. But again, you have to practice them proactively over and over and over again so that they get integrated into their system and their mind. Because if you're only bringing it out when they're anxious and doing it, your progress is going to be very, very slow. So you want to make sure you're catching them when they're in a good place. So challenging your anxious thoughts, nobody ever plays with me, to Johnny didn't play with me today, but Annie did, I'll never make friends, to I can't really tell what's going to happen in the future. Really learning some strategies to challenge themselves when it comes to those negative thoughts. And then the end goal is to really teach some self-awareness, because you want the children to know and learn how they feel as they're climbing that anxiety scale. So there's always going to be low-level signs of somebody being anxious, and that's when we want to catch the students and teach and have them start using their coping strategies. And so to start, you might be like, oh, you're rocking more and your hands are sweating. Those are signs that you're climbing the anxiety curve. Those are signs that you're starting to get anxious. You're modeling that talk for them. I've even sat down with kids and just created this chart with them, like some kids have really good awareness, like here's how I feel as I climb the anxiety curve, and then have them brainstorm with you if they can, what strategies they're going to use to calm them down. If you have a student that can't communicate that very well, use your team to talk about what that student looks like as they climb the anxiety scale and what supports we're going to offer for them to teach them to calm down, because you have to catch it early. Once it gets to fight flight, there's really not much you could do anymore to calm them down. Then it becomes, if they become aggressive in those stages, that becomes about keeping everybody safe. If they've shut down, there's not much you can do to get to them at that point. So you want to catch it early. You want to be having these discussions and explaining to the students how they look as they climb the anxiety curve. Here are just a few. A body scan would be a nice long-term goal, like, hey, do a body scan. You can start by that by checking in is an awesome book set to music by Emily Arrow. I don't know, I'm a huge Emily Arrow fan. She used to be a music teacher and she turns books into songs. But she has one on checking in, and it just goes through your whole body and checking into how it feels. So you could start there. You could also start in the moments of anxiety, labeling what that looks like for the student. The end goal being that you could just say, hey, do a body check right now, and have that student start just becoming aware of where they are on the anxiety curve and using a strategy to bring themselves down. You can also come up with a calm down routine or a plan. If it's really routine based, you provide a visual of what that looks like. You practice, role play, throw it on a video, let them watch other kids doing their calm down plan. Over time, hopefully, they will be able to start using that and making that their go-to strategy when they start to feel themselves getting anxious. And then I loved this for middle school, the amygdala hijack resource. So teaching them to go over to the amygdala hijack bucket, and when that downstairs brain starts to kick in, these are some strategies that you can use, and have that available for all kids. I mean, my goodness, all of us nowadays are getting amygdala hijack. That's why we have road rage all the time. And so that will help all students. Like if I start to feel anxious, if my downstairs brain is starting to kick in, I can go over to this bucket of amygdala, like this amygdala first aid kit, and pull out some coloring and do some mindful coloring, or doodle, or any type of do a Rubik's Cube, anything that's gonna help calm you down. Now you have to teach the strategies proactively, and you have to be role-playing those and practicing those over and over for them to be able to access it when they're starting to get anxious. All right, I think I'm done. Do you have any questions?
Oh, no.
We don't have time for questions.
No. Thank you. Oh, thank you so much. Do you have, though, a couple of questions for the sites that maybe can help them discuss what you just downloaded into our brains?
Well, is there 15-minute discussion time
Yeah.
now?
Oh, yeah.
I think they could talk about a student that they have and, walk through what they look like as they start to get anxious, like what the student behaviorally does, what they do, their body looks like, because that's going to be really important, because as we watch somebody get anxious, we ourselves also get anxious. And so if we're not prepared with what that looks like and what strategies to use to help somebody calm down, we're not going to be much help in those situations either. So.
Okay, so good discussion at the sites is think of a student and just talk about, what does that look like? What does anxiety look like for them? I think that's a fantastic discussion. Along with, I think there were a lot of resources. So discuss, where might you be able to implement some of the resources? And I really appreciated the take time to teach calming techniques when you're calm. If we spend more time in those calm times and those positive times, then it's going to be easier to deal with the stormy times. So thank you. I would encourage the sites to spend about 15 minutes in discussion. If you go 10 to 15 minutes in discussion and then take another bathroom type break, we will reconvene at 11:30. So we will come back online at 11:30. Thank you. Yeah, that's my job, is piecemeal.
And you think you're the murderer, and this person
That would explain why people kept talking in this room as I was continuing to talk, and people at the sites were going, turn it up, turn it up. So yeah, there we go. When I turn the microphone on, it tends to broadcast better. Weird, I know, really strange. So thank you so much. For those of you that have been with us the whole morning, we are anxiously awaiting, well, hopefully not too anxiously, because we're trying not to be anxious today. Anticipating. Well, Megan will be up in just a couple minutes, so however you want to feel about that, feel about that. I have greatly enjoyed this morning, but I do have a few announcements that I need to make before we bring Megan up so that I don't have to do them at the end. Number one, unbeknownst to me and unplanned by me, y'all who are joining through YouTube and from your personal computers and stuff like that, y'all have been having a heck of a conversation going on. Somebody shared with me the chat that's going online. And I want to thank you all for interacting with each other, for being part of that community together. I did not foresee that. So thank you for that. I don't know if I'll do anything different next year, but y'all are taking care of each other. And I thank you for that. Speaking of taking care of each other, what I have neglected to mention is that if you are a parent or a provider or someone who has interactions with children with special health care needs, please remember that there are 5 regional centers for children and youth with special health care needs throughout Wisconsin. We are here to offer information and referral resources, to offer parental support. We want to walk this journey with you. So if you have any questions about just Google Wisconsin Regional Centers and you will find the one closest to you. If you're in Madison, the closest one is downstairs on the first floor. So feel free to talk to me afterwards. There are also a number of autism societies, affiliates throughout Wisconsin. Autism Society of Southeastern Wisconsin, Autism Society of South Central Wisconsin, Autism Society Greater Wisconsin, as well as some smaller community as well. There is support, maybe not right around the corner, but there is support available for you from people who understand and have been walking down that journey that you've been walking down. They would love to partner with you. After we are completed, so after I turn it totally back over to the sites, later this week, you will receive an evaluation. It will be an electronic evaluation. You will also receive information if you would like to have a certificate of attendance about how you can get that. The sites need to send me the sign-in sheets as soon as they can, scan and send those to me, because I then have to verify the attendance on the sign-in sheets to send it to UW Superior to be able to, for them to give you the CEUs. So I can't release names for CEUs until I get them from the sites. So I need those back. Other than that, part of the evaluation will be, hey, what do you want to talk about next year? I'm hopeful that we'll get to do this again. I really, really enjoy it. So with that, that is my announcements. And so I'm very excited to bring up someone who has spoken at the Community of Practice before on a different topic. Dr. Megan Farley. She is a licensed psychologist in private practice at Different Minds. She also works at the Weisman Centers in our clinics. And so I'd like to bring her up, and we're going to close with suicidality and autism, a topic that I just do not think is talked about enough that we really need to begin to pay attention to. Thanks for being here, Megan.
Hello. I'm really excited to be here this morning and really excited to talk about this topic. It seems like it's, going to be a sad topic, a difficult topic, but I will give you a spoiler that in the course of researching this topic, I became really excited by the direction that this research is taking and some of the really cool things that people who research this topic are doing in their actual research, like how they're conducting their research and also what their research is pointing towards. So hopefully you'll be excited too as we go through this. I will just tell you, suicidality is like a geeky term in the suicide world that refers to suicidal ideation, ideas that people have about suicide planning, and also behaviors and actions that people take towards suicide. So it just encompasses everything that we think about when we're talking about suicide. So I'm going to start with this obligatory acknowledgement that I don't have any conflicts, and then we'll talk about learning objectives. So we're going to review major outcomes from research on suicidality and autism spectrum conditions, which is kind of a preferred term for a lot of people. So this research that's been done so far. So this research, there's a little bit of it prior to 2014, but in 2014 there was kind of a really important study that launched this, so it's not a very old field of research in the world of autism. We'll talk about major risk factors for suicidality and autism spectrum conditions, and then talk about some ideas to support people who have autism spectrum conditions that they themselves as a community can do, and also the rest of the world who care about them and cohabit the planet with them can do to help mitigate the suicidal ideation and behaviors that people have. So looking at major research findings in suicide in the general population, suicide is the second leading cause of death in the United States for youth and for young adults, so people in the age groups from 10 years of age to 34 years of age. It's the 10th cause of death overall in the United States. In the general population, 17% of adults report having the experience of suicidal ideation, and then about 0.8% of adults endorse attempting suicide at some point or have attempted and completed suicide. Most suicides in the general population are completed by males, and the gender ratio is 3.5 males to every single female. It's always funny when you have a fraction for a human being. And then depression is a major risk factor. We also know, of course, there are many other risk factors like sort of hyperactivity or impulsivity is a major risk factor for completing suicide. In people with autism, suicide is the leading cause of premature death for autistic people, and that result comes from a very large Swedish epidemiological study that was conducted on a population of adults with autism. The prevalence of suicidal ideation in people with autism is 72%, and going back to the general population, it's just 17% in the general population. Then prevalence of attempts from a review of the literature that actually only found 4 studies, identified a prevalence of attempts of 7 to 47 in people with autism, and then is less than 1% in the general population. And interestingly, in people with autism, women are more successful in completing suicide than men, which, as you recall, is very, very different from the general population. So that is an important result that I want you to keep in mind as we go on and talk about what people are starting to think about how suicide sort of develops in people with autism, suicidality. So there was a population-based study, an epidemiologic study in Taiwan, where they looked at adolescents and young adults, 5,618 adolescents and young adults from a database that those individuals had autism spectrum condition, and they had 4 times the number of matched controls. So within a period of 3.5 years after they entered the study, so that could be either right at the start or when they were diagnosed with autism and entered the study, within a period of 3.5 years, almost 4% of the people with autism attempted suicide. And in a period of 6 years, less than 1%, 0.7% of the matched controls attempted suicide, so a huge difference in youth and young adults with autism. Risk factors for suicidality in autistic youth include, so there have been a couple of studies that have looked at this. One of them, let me just find my notes here, looked at a 2013 study. They looked at 791 children with autism who were 1 to 16 years of age, 35 children with depression without autism, and then 186 youth who did not have any kind of clinical diagnosis. And there were 4 demographic variables that hung together in 71% of the kids who, 71% of the kids who had these 4 demographic variables committed suicide. Or attempted suicide rather. They were kids who were over 10 years of age, Black or Hispanic, had low SES, and male. And then psychological factors that contributed to attempted suicide or ideation in almost half of the kids with autism included depression, behavior problems, and a history of being teased. And we know from adult research that a history of being bullied or teased is really closely associated with limitations in subjective quality of life. So, another study controlled for demographic variables and autism symptoms and found that increased impairment in emotional regulation in kids was associated with suicidal ideation or behavior as reported by parents. And so that went both ways when we think about emotional regulation. So there is emotional regulation where people act out and they're very reactive to things that happen in the world. And then there's also problems with emotional regulation where people are just, it's called dystonia, where people are just like at a really low kind of regulation and they can't upregulate themselves to experience excitement and happiness and things like that. And so when people had either or both of those going on, they had increased risk for suicidality. Another interesting finding is that, and it's sort of like kind of obvious, right? Self-injurious behavior, so non-suicidal self-injury is a risk factor for attempts and ideation and later sort of suicidal type of acts. But we often think of that type of behavior, especially in young people or in people who have intellectual disabilities, as being just part of their autism, right? Like we think of self-injury lots of times as this repetitive behavior or a sensory thing, and it may be a challenging behavior that we try to eliminate through applied behavior analysis strategies and things like that. But really what this research is pointing to is that people who have these behaviors as kids oftentimes develop into older people who have pretty high risk for suicidal ideation and suicidal behaviors. So these aren't necessarily like behaviors that need to be addressed by other people as much as they are a real indication of underlying significant distress. And so Jeremy Veenstra van der Wiel is a psychiatrist who wrote this in an editorial about the importance of studying suicidality in autism. The increased risk of self-injurious behavior in younger and less cognitively able children with autism spectrum disorder is matched by an increased risk in suicidality in those at a more advanced developmental level. Some studies have looked, of course, at risk factors for suicidality in autistic adults. And so some of the things that they found are agitation during a depressive episode, a history of suicide attempts, and then autistic traits themselves and an autism diagnosis. Those are things that have been found over and over and over again to be closely associated in research with increased suicidality, which is sort of circular reasoning in a way, I guess. But it's something that we'll talk about more later in a model of suicidality. Social camouflaging, which many of you probably are aware of, but is this phenomenon where people with autism try to compensate for their autistic traits or cover them up with sort of more pro-social behaviors, is closely associated with increased suicidality in people with autism. And then, of course, depression, just as it is for anybody else, is associated with increased suicidality. And there was a study that looked at loneliness and it found that loneliness is a contributor to depression, which then is part of the pathway towards suicidality for people with autism. So people flip this on their heads. We flip everything on their heads and research things the other way, looking at autistic traits in populations of people who have attempted suicide. One recent study from 2019 reported that 40% of adults who attempted suicide met the cutoff for autism, like significant autism concern on the autism quotient, a questionnaire. And then there have been several studies by this group out of England that have identified self-reported autistic traits associated with suicidal thoughts and behaviors. So this is an important thing, and it's kind of a weird thing in suicidality research on autism, is that they often look at people with autism traits and not necessarily with autism diagnoses. So why might that be, right? There are not, objectively speaking, there aren't that many people with autism compared to the general population. And then of the people with autism, there aren't that many really who attempt suicide, and so it makes it really hard to study that. And so they look at autism traits in people and how that is related to suicide. And actually, I was sort of questioning whether or not that was a good idea, like my own authority, which is legitimate. But then it's, you know, as I read more and more, it does seem to be like a pretty good approach to a pretty creative and useful approach to solving this problem. And super important, turns out, when it comes to adults with autism, because lots of adults with autism, if we think about like the kids who are being diagnosed today and what they're gonna look like when they're adults, and many of the adults maybe who are not diagnosed now, who might have been diagnosed as kids if they had been evaluated using the criteria we use today, there are going to be a lot of them that are sort of subclinical, who sort of are better characterized by the term broader autism phenotype than by the strict diagnostic criteria that we use these days. So lots of people with very clear histories of what we call autism now, who will acquire different types of skills so that they don't objectively meet the criteria for autism explicitly in adulthood, but still have lots of characteristics, right? So people with very subtle symptoms of autism. So that makes this an even more useful approach to looking at suicidality in people with autism who are adults. So I want to tell you about this very interesting model of suicidality in autism. This is what it is. We're going to talk about some of the vocabulary, and then we'll come back and look at it again. This model is, it comes out of actually just research on people with suicidality in the general population. This researcher, Sarah Cassidy from England, has taken this model and extended it to apply it to populations of people with autism. And so that's what we'll talk about. She's probably the most prominent researcher on suicide and autism. Oh, and I'll tell you that her first major paper in 2014 on this topic looked at 367 adults who were getting a diagnosis of autism for the first time and how they experienced suicidal ideation and attempts. And so in that population, 367 adults, many of whom are women, 66% of the adults in that sample reported that they had contemplated suicide, and 35% of them had planned or attempted suicide. So huge numbers from this pretty large group of adults with autism symptoms. So let's get oriented to this model before we explore it in detail with a couple of definitions. One is thwarted belongingness. So thwarted belongingness refers to the absence of reciprocal relationships, so you don't feel that you belong, or you actually don't have the experience of belonging in your social world. Another one is perceived burdensomeness. I've never tried to say that out loud before. Burdensomeness. It's a perception that a person has become a hopeless burden on their family and friends, right? So let's go back to this model now. In the general population for this model, the strongest predictors of suicidal behavior, and this is true for people in the general population as well, mental health conditions, previous suicide attempts, social isolation, family conflict, unemployment, and physical illness. So lots of people experience some of those things, or even many of those things, but they don't commit suicide. So the notion is that those are like distant risk factors that contribute to proximal risk factors that actually really contribute to the experience of suicidality. So those things contribute to these two major variables of thwarted belonging. I don't know if there's a point there. There's a pointer, isn't there? This thwarted belonging, you see it, and then perceived burdensomeness.
They will not be able to hear you if you're with
Oh,
them.
thank you. Thank you. Sorry about that, folks at home. Oh, I can use, oh yeah, okay, good thinking. Well done. Okay, so those different, those different variables contribute to this thwarted belonging or perceived burdensomeness. And the theory is that if you have one of those things happening, you have thwarted belonging or perceived burdensomeness, then you experience passive suicidal ideation. If you have both of those things happening, the thwarted belonging and perceived burdensomeness, you have what they refer to as the experience of a desire to die. But in order to actually attempt suicide, you have to have a third variable, which is a capability for suicide. So you have to have a plan and then like a reasonable way to execute that plan. So those three things are necessary in order to attempt suicide. And different mental health conditions, as you can imagine, contribute to these proximal variables like depression. You can think about the ways in which depression would contribute to thwarted belonging and perceived burdensomeness. So with thwarted belonging, like you don't get out that much, you're sort of isolating yourself. People maybe don't actually want to hang out with you that much because you're kind of a drag over time. Perceived burdensomeness, you just may feel like you don't have anything to contribute. And so you can imagine how that works with depression. Psychosis also is a condition with a high rate of suicide where this sort of thing can come out. And then in autism, we can think about some of the characteristics of autism that contribute to these types of experiences. So in the case of perceived burdensomeness, there are these characteristics of autism like, or characteristics that we see in people with autism, like caregiver burden, unemployment, physical and mental illness, poor self-esteem, agitation, that make people perhaps feel like they're a burden and get the message that they may be a burden. And then autistic traits that may contribute to thwarted belonging include things like increased risk of social isolation, the experience of loneliness, and difficulty establishing reciprocal relationships. So, taking this model a little bit further, there's this notion of camouflaging, which additional research that this group out of England, Cassidy's group, did, showed that there's a very strong connection between social camouflaging and the experience of thwarted belonging, which totally makes sense, right? Like, I don't belong, I have to change who I am in order to fit into this situation. So camouflaging comes from people with autism. People with autism have been talking about this for a really, really long time, right? Like Leanne Holiday-Willie said, Pretending to be Normal was the title of her book. People have talked about this for a really long time. And people haven't been really looking at it until very recently. So camouflaging is actively attempting to mask and compensate for autistic traits in social situations in an attempt to fit in better socially. In one study, they asked people why they camouflage, and one woman said, mostly to avoid the bullying. And so when there are different components of camouflaging, and the component that was most closely associated with that thwarted belonging is assimilation. Assimilation is this experience of just having to merge with the Borg mind or, connect to the sort of typical general population socially. It taps into a feeling that social interactions are not natural or genuine, and you need to pretend or put on an act. And as I was learning about this and researching it and typing it up, I was thinking of times when I have encountered autistic adults who I think of as friends, where they've challenged my own social behavior and been like, why are you acting like that? That's so weird. Like, stop, just say what you mean. And I have been like, oh, you're right, but I don't know how to be different in that situation. So it was just a really interesting experience that I've had, thinking about what it's like for them, and them feeling the comfort of being able to say, like, this is how I experience you, and it's just not cool. So anyway, thank you for listening. So harm from camouflaging in this model, as they have sort of fleshed it out over time, shows that camouflaging autistic traits, oh, and by the way, this has been borne out in people who have subclinical autism, who have autistic traits, but not the full diagnosis, right? Camouflaging autistic traits in social situations leads to increased feelings of thwarted belonging, which then leads to suicidal thoughts and behaviors. So what does that mean for how we function in the world, and what we've been asking people with autism to do for a super long time, and even demanding that they do? Right. Most of our current approaches place the onus on the person with autism to change, right? Treatments seek to make autistic people act or think differently. I teach social skills, and I'm asking people to be different all the time, and I tell them all the time that the reason why I'm doing it is so that they have a choice to behave in whatever way they want in different situations, so that they can reach their goals. I don't know if that's me making an excuse for what I'm doing. I don't know, but that's what we do, and we do that a lot. There's a quote from Mitchell in the research study that group did, a growing body of research consistently showing the negative consequences of camouflaging autistic traits in social situations, demonstrating well-intentioned but potentially damaging consequences of this traditional approach. Other research has shown that there's this situation, they call it a double empathy problem, where people who are not autistic have trouble interpreting the behavior, intentions, and intentions of autistic people, and that can lead to people without autism rating autistic people less favorably. So, future interventions could focus on helping non-autistic people more effectively interact with autistic people. Reducing the emphasis and pressure for autistic people and those with high autistic traits to camouflage their true self could even help prevent risk of developing mental health problems, suicidal thoughts, and behaviors. And I will note that I have obviously so much regard for this Sarah Cassidy. She, in her research, uses the language that adults with autism want people to use, and she also uniquely included 8 adults with autism in the development of her research, in writing the questions for the instruments that she used, and deciding what was important to research. And so they had a lot of really interesting results that I'm not talking about today, that aren't directly related necessarily to this topic, but it's really exciting to see people who are active in research taking these approaches that are so important. So some new bases for future interventions could be and things that people have called for in the recent past, are improving the fit between the person and the environment by modifying the environment and not asking the person to change to fit the environment. And we have some tools that I think have a lot of potential to be really useful. In the pretty recent past, people identified variables for the International Classification of Disability Functioning and Health, the World Health Organization's guide to how people participate in the world, successfully or unsuccessfully. So I think that's an area that's really has a lot of potential to be a useful way to look at research in this area. Also teaching non-autistic people to interact with autistic people more effectively. And of course is related then to reductions in social stigma as well. But then there are areas that are really important that people with autism have identified, and that researchers without autism have identified as well in the course of their research, that we need to continue doing, like helping people improve coping skills just as we do other people who have depression. And people with autism maybe do have a potential to have more challenges with coping skills associated with depression because of difficulties they may have with imagination and flexible thinking and things like that. So that's an area that can use some continued work, certainly. And then mitigating problems with emotional dysregulation could be very helpful for people. Improving employment outcomes, supporting social participation, reducing loneliness, all these things that people have been, have been on people's radars and people have been working on for a long time, could certainly continue to be useful. So that's all I've got for you all. And I think it might be, yeah. Okay, I sure will. And where will I hear those from? where would, questions from this site. Okay, thank you, yes, sorry. I was like, got it, yeah, okay, thank you. Yes. Yes, Tina, yeah.
What would a training class for non-autistic people who interact with autistic people better look like?
Mm-hmm.
Teach them.
What do you think? Oh, yes, sorry. What would a training class for non-autistic people to better interact with people, with autistic people, look like? So I said, what do you think? And then someone else said, it depends on the age. I wonder what other people think. What I think is that it probably would be many sessions, and it probably would be inadequate, just as social skills groups for kids with autism to try to participate in sort of neurotypical situations, neurotypical social interactions would be. So necessary but insufficient. I think it would probably address a lot of the challenges that we have identified that people with autism have, that people with autism have identified that they experience in interacting with other people, and then talk about ways to appreciate what they're trying to do. Probably involving people with autism in those groups as well, if possible, would be super important. I don't know, that's what I think, off the top of my head.
The thing that has been most helpful for me over time was to be able to understand how different their thought processes and interactions are than mine are, because it's very surprising to me some of the sensory stuff that happens that doesn't happen to me, and that type of thing. So
Yep.
I think that would be the first order of business for me.
Yes.
To be able to reveal how their lives are different on the inside and the outside than mine are.
Well said.
You know, so
Yes. Yeah,
it's
what,
a place to start.
Yeah.
It's a place to start.
yeah, what Nancy was just saying was understanding, like what's been most helpful to her is to understand what the experiences of people with autism, of autistic people, have been in terms of like sensory processing differences and things like that. How do they experience the world from the inside and the outside from them? And I think about, you know, this so often said thing about how you met one person with autism, you met one person with autism. So like you get to know autism, I think, through meeting lots of people with autism, right? And so you have to have lots of representations of people with autism to start to come to a little bit of a crystallized understanding of what it is. James?
I think one other thing too, and this is probably the most important thing, and this is an issue that I've had with non-autistic people and autistic people, like, and that is you have to be willing to openly tell us when our natural way of being is offensive. And, like, I've had old-time friends who I've known for years just suddenly, out of the blue, stop talking to me because I did something that offended them so badly, and they never gave me the benefit of learning what it was that I did.
What a beautiful thing to say. So James just said one of the what he feels is the most important thing is for non-autistic people to be able to tell autistic people, and probably also other non-autistic people, what it was in their behavior that offended them, because he has had the experience of having longtime friends who have suddenly stopped talking to him because of something that he did that offended them, but they never told you and you couldn't rectify it, right? And that's so uncomfortable for non-autistic people to do. It's really hard, but you could do role plays, just like we ask autistic people to do in social skills groups, to practice that skill and get more comfortable with it, and then see, maybe with autistic people, that it's actually, like, the fallout isn't catastrophic, right? It's actually really helpful, and having that experience could help people.
Well, because not just the people I meet, but I think about how I meet a lot of people with autism who are part of these social subtypes where their behaviors can be really scary. And these behaviors, which their minds are telling them to engage in, inherently scare a lot of people. And it's really sad, like you want to talk about inclusion and acceptance, yet you deal with people where their brains are telling them to engage in these very scary ways.
James was just commenting, he didn't want to offend anybody, but wanted to make the point that he interacts with a number of people, autistic people, who whose brains tell them to behave in ways that are scary, and you want to talk about inclusion and support that, but it can be really challenging when there actually are people who are behaving in ways that are frightening to, scary to other people, and their brains are telling them to do that. Yeah. Sorry.
How to address that without hurting their self-esteem, right? Anyway, that's the other challenge of at the end of it.
Do you mean, it's so sorry, and I will repeat that in just a second, but do you mean for neurotypical people to address that with them without, or other people to address that with them without hurting their self-esteem?
Correct.
Yeah.
Really anybody.
Yeah.
So, if they have behavior, I mean, my experience is mostly with children or younger kids, and it's like if they do things now, it's okay, it could be cute, like it's not a problem now. But when they're an adult, when they're a 25, 35, 40-year-old man doing the same thing, it's going to terrify people. So how do you, especially if they're older and they're already adults, like how do you address that without also hurting their self-esteem? Because if somebody came to me and said, oh, what you're doing every, 3 times an hour is terrifying people, like it would make me feel bad. So, because I don't want to terrify people.
Right.
So, and that's normal, like people don't want to scare people, right? So,
Yeah. Yeah, so somebody was just commenting that the question is how do you do that? How do you provide people with corrective feedback without hurting their feelings? And how she would feel very hurt if somebody gave her really direct feedback that something she was doing was scaring her. And I think that is a really important topic for conversation between non-autistic people and autistic people, is like, how exactly do we do this? I think for many people with autism, or autistic people, sorry, I'm really trying to say that, that they have, that it isn't gonna hurt their feelings necessarily, and oftentimes if it's said with a good intention, and you're open to having a reciprocal conversation about it, then they're gonna feel like they wanna know that information, right? Like they want to be able to be equipped to be accepted by other people maybe. But that's, maybe not everybody, yeah.
I was just gonna say that oftentimes I'll address that in a proactive situation with like characters, or get a children's book that teaches the same concept, because those are the kids that I see middle and high school that are very, very self-critical and very sad, that they've made mistakes, and like you said, every time they make mistakes, somebody does a fix-it plan with them afterwards. And over time, that really affects your self-esteem. So like proactively start changing these situations up and make them, like talking about them not from the mistakes that they made. None of us learn as well when we're being critiqued on our own behavior. So it's a little bit harder to accept. And so just over time, I think that can be very damaging to self-esteem.
Right, okay. So the comment is that over time, it can be really hard to hear this like fix-it solution for every behavior that comes up, and that over time it can be really damaging to self-esteem. So perhaps doing something like taking a book that has a character who encounters a similar situation and then being able to talk about it might be a better, more sort of palatable way to get at that sort of thing. Because as time goes on, people get this fix-it situation over and over again that can be really, really demoralizing, right? Yeah, Nancy? Sorry, Tina.
One of the tools that they use for these discussions are social stories. I think everybody's heard about that. And I think it's important not only to do that as something where you have a problem to work on, but when you have something to celebrate. So put it in writing when there's something to celebrate, not just when there's something to fix, and make something out of it.
Yes. So the comment is to use social stories, but to also use them in times where there's something to celebrate, where people have done something really well, and you celebrate it by writing and reviewing that social story. Great idea. Tina? Yeah.
It's a different topic, but because of the increased rate of suicidality in women, is that because they're better at social camouflaging, which then raises their risk?
Yeah. Yes, well done. You all passed the test. The excuse me. The question, the comment is the increased rate of suicidality in women, is that because they camouflage so much that you know, that they're so successful at it and that they do it so much. Yeah, that's what some of the researchers were hypothesizing was very likely the case, that they have a much higher experience of that thwarted belongingness, and oftentimes they can't even get a referral for diagnosis because nobody believes that this is a relevant thing for them. Yeah, James.
Do you want to point out a side note? This is something I have to thank Prominent Self-Advocate Nina Gassner for pointing this out. Like other female self-advocates, she's pointed out female camouflage factor. But one thing she's also come to realize, and I've observed this too, is that another possible issue too is that men try to camouflage, and they aren't always as successful.
Ah, good point, good
So
point.
they don't always continue. And I think about how in Wisconsin, I'm not going to name the city, there's a social group that has successfully finagled, because they accept anyone who has tendencies, they've finagled a group that has always been half female, half male.
Wow.
And because their group is not male majority, they don't have a male majority group, one thing I've observed is that both the males and the females are working just as hard to be socially accepted and appropriate in this group, yet the males are being reprimanded far more often for terrifying other people in the group than the females are.
Wow.
And what amazes me is that the men often feel frustrated that people are often swooping down on their inappropriate behavior, whereas the females are often camouflaging their behavior, and they are being reprimanded as being terrifying to others.
Wow. I'm not sure that I can repeat that all, but I will just try to summarize and let me know if there's any major points that I missed, James. James was just commenting that there is a self-advocate, female, Dina, whose last name I didn't get, Gesner, who's prominent, who describes how females camouflage, males camouflage as well, but maybe are not as successful at it as females are, and that there is a social group in a city in Wisconsin where they accept people so widely that there is a like 50-50 composition of males and females, and the males are frequently corrected for their social gaffes or scary behaviors, and the females are not, because but everybody in the group, females are not as much, but everybody in the group is working really hard to participate socially, right? So, okay, yeah.
I just want to throw out that there's a really good resource by Patrick Schwartz, Possibility to Success, that has some great questionnaires for teens about that sense of belonging.
Oh, great.
In whatever environment they're in, their community, their school.
Great.
That might give people more information on how well somebody feels included and belonging, that sense of belonging.
What is it called again? Pathway?
Possibility to Success.
Okay,
by Patrick Schwartz.
Possibility to Success by Patrick Schwartz is a resource that for teams that gets at people's sense of belongingness, how successful they are at helping people to have a sense of belonging.
Belonging and how well they're included in their environment.
And how well they're included in their environment. Thank you. All right, thank you so much for your attention and participation.
Thank you so very much. There was so much impactful in that, Megan. This whole morning has been a joy and a challenge at the same time. And before I release you for the last time, just please make sure you tell your site leaders thank you. Your site leader, just so you know, is Radine, who's up there. I'm just a figurehead. Radine does the work. But thank your site leaders, because without them, we wouldn't obviously have sites. Thank you, too, for the fact that we again spanned 2 states. So from our distant friends in Minnesota, thank you for crossing the border and coming to Wisconsin, where we are learning great things. Next year, Canada. We're going to have somebody from Canada. That's my goal. And then finally, people have been asking about certificates of attendance. I will have instructions for those with the evaluations. For the sites, the question that I would, I love the question, what would a training look like for neurotypical people to teach them about how to interact well with people with autism or neurological differences. I think that's a fantastic discussion. It makes me wonder, so please feel free to discuss that. And then closing, just a couple of thoughts. Number one, as soon as somebody wins the lottery and gifts me with a lot of dollars, you are all invited to my new neurodiverse friendly communities, where we go in and we teach businesses and libraries and people every day how to interact with neurodiverse people. And so we will start to have neurodiverse friendly communities so that everybody is free to go shopping and everybody is free to go to the bar. Not that I'm promoting drinking, but it is Wisconsin, and that seems to be a rite of passage. But that's beside the point. Wellness Coalition people, I'm sorry about that. But I really think we need to look at it bigger, as what does it look like for our communities for neurodiversity, so that everybody is accepted. And then at the core, as I was reflecting on what Megan was saying, autistic people, non-autistic people, at the core of life is relationships and hope. If we could just reach out in our everyday lives, help people build those relationships, be in honest reciprocal relationships with people, have someone there that you know cares about you, someone there that you care about, have a relationship, and then help each other continue to have hope. Believe that no matter what we're going through, we will get through it together. That tomorrow truly is another day. That sometimes sleep is the best dang thing that you can do for yourself. Wake up to a different reality. Relationships and hope are what keeps us moving forward. And so we extend that to our autism spectrum disorder community, as well as our developmental disabilities community, as well as, well, gosh darn it all, that is just a human need. So go out, build those relationships, give each other hope, and hopefully we will see you all here again next year. Thank you.